Two, 1, 2. Test 1, 2. 2, 1, 2. Good morning, everybody. Just an announcement. There's a Kia, white Kia, left the lights on, CY448. What's that? 833. A white Kia, left lights on.
Good morning, everybody. Please start making your way in so that we can start. I'm going to give it 2 more minutes. I'm using that clock over there.
We've got a quorum.
What else does that go? Of the AAVC. Yay, there's light at the end of the tunnel. I hope you had a good night's rest and a good breakfast and a strong cup of coffee and are ready to go. So day 4, we're going to do, you can read from your program, the missing link, vaccinating underserved and unreached populations in Africa. I'm going to chair the first session for those of you who haven't met me personally. My name's Chris. But what's more important is our first speaker is Dr. Anthony Hawkridge, who's going to be speaking on zero-dose children and missed communities, ensuring that no one is left behind in the African immunization agenda. So Tony is a specialist in public health. He's got extensive experience having managed districts for the Western Cape. He's currently part of VACFA. And I have to say, after Sunday Night Song, he has cemented himself in my list of heroes. So, over to you, Tony.
Thank you, Chris. Morning, everyone. I'm a bit worried about being in a session called The Missing Link. Do I look like the missing link? Anyway, how are you we over the hump, eh? The hump is Wednesday. So we're now on the downhill, and tomorrow's a half day, I think. So, but yeah, well done on making it this far. It's pretty intense. Okay, so I've got 40 minutes to talk to you about zero dose, and I think I've met most of you, so I'm not going to introduce myself. The talks about the challenge of zero dose children and how addressing that challenge fits into the African immunization agenda. So I'm going to ask you a question later on. You can think about it in the meantime. But the Declaration of Addis Ababa of 2017 only has 45 signatures on it. And there's 54 countries in Africa. So we'll get back to it, but which ones were missing? You can think about that. All right. So I'm going to be going through quite a lot of information, and I'll be going quite quickly. And the reason is that I'd really like to have some time at the end where we can almost brainstorm and figure out what to do about zero-dose children in Africa, but with the background of a lot of the research which has been done. Okay. So first up, I think we just need to make sure that we're all on the same page when we talk about zero-dose children. So here's a standard definition. So zero dose refers to no vaccinations. So a child who's had no vaccinations at all. We also talk about under-immunized children. So that's a child who's had one or more vaccinations, but zero dose, no vaccinations. And we're talking about routine vaccinations available and usually applied to lower middle income countries, so LMICs. And we're not talking about all the many additional vaccinations which are available in high-income countries. We're talking about vaccinations through the National Immunization Program, because that's where most kids in LMICs get their vaccinations. Okay, so we agree now what we're talking about and why it's important. It's important because these children are at very high risk of falling ill and of dying. We know that. But they also face additional risks compared to children who have received most of their other vaccines. And we'll talk about what those other risks are. The most obvious one is that they're at risk of getting the diseases against which they haven't been vaccinated. But I think the point of this lecture is that they're also at additional risk of other things. And we want to explore that. There's other factors which characterize these kids. Okay, so I'm going to be referring to lots of publications, but this one in particular, this one from UNICEF, highlights inequity, poverty, access, migration, refugees, and remoteness as important factors for the ZDCs. This particular group of kids, as a group, they tend to, I've said to live on the edge. Either they literally live on the edge geographically because their homes are far away from the health services and other amenities, or they live on the edge figuratively because their communities, the communities that they come from, are excluded and marginalized from the mainstream of society. Children living in conflict areas and war zones are at high risk because war disrupts the services which should be delivering their vaccination. And it also destroys the infrastructure. So how do you deliver a service where your buildings have been reduced to rubble and your electricity and water supplies have been disrupted and your roads have been rendered impassable? And I think we all know of examples of where that's happened in the recent past. Communities may be marginalized for many reasons, and common ones would include poverty, but also things like religion, ethnicity, political allegiance. You'll have a community which is just pushed out to the edge, and the children in that community are at risk of not getting their jabs. This is saying much the same thing. These children come from, they've called it complex contexts, and they face multiple deprivations. So it's not a simple one factor causing one outcome, and therefore you just address that factor and you solve the problem. You'll see as we go on, it's much more complicated than that. So it's multifactorial. But there's this theme that runs through it, and I think referring back to Radzani's lecture earlier in the week, this whole theme of poverty, and it's so important in Africa. Somebody mentioned, I think a colleague here mentioned gender discrimination earlier in the week. as an issue. Is that a risk factor for ZDCs? In South Africa, gender discrimination is illegal. It's against our constitution, but you'd have to be very naive to pretend that it doesn't happen. So here's some stats about zero-dose children, and forgive me if I refer to them as ZDCs. I know you know what I'm talking about. But also I encourage you to go back to Michelle's lecture from the other day and just cross-check this, because she also had quite a lot about ZDCs in her lecture, probably from different sources, and just check whether the numbers match up. But I like round numbers because they're easier to remember, particularly when you're over 60. So in 2024, there were around 14 million ZDCs worldwide, classified as ZDCs. And there were two flags, red flags here, which kind of rose up for me. Firstly, there's an increase of about, you remember from Michelle's lecture, she said, oh, well, we've had some progress. Okay. I'm not sure. Firstly, there was an increase of about 10% on the number 5 years previously. So they give you the 2024 figure. If you look at the 2019 figure, it was up by about 10%. And secondly, it was 40% higher than the IA 2030 target that we had actually set ourselves. So that doesn't sound good. Most of it was in LMICs in Africa and Asia. I think we would expect that. 1 in 7 children in Gavi-supported countries was classified as zero dose. And half of the children, so around 7 million of the 14 million worldwide, come from just 10 countries. And 5 of those are in Africa, and those are Angola, DRC, Ethiopia, Nigeria, and Sudan. So we're talking about raw numbers now, and we'll talk a little bit more about proportions later. So I think you'd agree with me, it's a pretty bleak picture. Okay, so here's a busy slide, and I need to try and explain it, but it comes from the IA 2030 progress report. So IA 2030 has been around for a while, but in 2024, they wrote a progress report. So going to the figure on the left first, what that figure does is it lists countries in the world by ascending DTP1 coverage in 2023. So at the top, you've got the country with the lowest DTP1 coverage in 2023, which just happened to be North Korea, I think. And at the bottom, you've got, out of this selection, the one with the highest, which was China. All right. And then it inserted into that list the rankings of the countries by absolute numbers of zero-dose children. So I think intuitively you would expect that a country which has got low DTP1 coverage might also have large numbers of zero-dose children. I mean, that sort of makes sense. But if you look carefully, there are countries which have got low coverage, which are not in the top 20 list of ZDCs, and there's other countries which have got fairly high coverage, which are in the list. All right. And the one which I've highlighted there is my own country of South Africa, which the reported DTP1 coverage there is 81%, I think, but it's in the top 20 when you look at the number of ZDC children, 220,000. And I think Greg referred to that in his opening lecture a couple of days ago. So that's the graph on the left. The graph on the top right speaks, I think, to what Michelle mentioned about what's been happening in the last 20 years. So if you disregard that little blip on the right, which is what happened in COVID, I think with the eye of faith, you can say, well, you know, the things are coming down, and then you've got that dotted line which goes over to the right, which is the targets. But again, I think there's some caveats or red flags there. And the first is that most of that decrease that you can see was in the first 10 years of that 20 years. And that actually in the last 10 years, there hasn't really been much. And then we had COVID. So that's the one red flag. And secondly, if you look at Africa, which is the dark sections of the stacked histograms at the bottom, actually there hasn't been much change in the absolute numbers in Africa over the 20 years. It went up, then it went down, and went, you know, the sideways and so on. The population of these kids in Africa obviously has gone up. So if those are the absolute numbers, then the proportion has probably come down. But I think the point is that the there are still millions of children in Africa who are zero dose. So I can't really say I'm thrilled with the progress that we've made. All right. And at the bottom right is just a reminder that as far as the target that we set ourselves, we are what they call off track. Okay. So then I said I'd get on to proportion. So it's not fair to take like the absolute number of children in zero dose children in Nigeria being over 2 million and say, well, they're doing far worse than South Africa because South Africa's only got 200,000. I mean, you have to try and relate it to the total population. So what I did here was I took those same numbers and then I added the total population figures and I worked out a proportion. So the number of zero dose children per 1,000 population. And then I applied it to the countries which are listed there from Africa. So you can see that on the left-hand side, we've got Central African Republic, which had the highest proportion at around 18 per 1,000. And on the right, you've got South Africa at 3.3. So what does that mean? So Central African Republic, I think, has got a total population, and I know we've got one colleague here from the CAR of about 5.5 million. And they had 104,000 ZDC cases. Okay, so they had a proportion of 19. South Africa, 220,000 ZDCs, population is more than 12 times that of the CAR. It's about 65 million, so 3.4. And in the middle, Nigeria, which has got, as I say, over 2 million zero-dose children, but it's got a population of like 238 million. So their actual proportion is not as high as in CAR. I think it's a fairer way of looking at it. But also I think it helps us to maybe interrogate a little bit more if we're looking for the causes. So I look at this and I see, okay, CAR, Somalia, Sudan, Guinea, Angola, yeah, but maybe those are the ones that are really battling the most with conflict at the moment. Okay, I see South Sudan's over that side, but maybe that's an outlier. So maybe that's a hypothesis we can test, or maybe there's other things. All right, so that's what I did. And I tried to relate it to conflict. So how do you measure conflict? Well, if you go to search for it, there are various indices that you can use. And I tried a couple of them. The one is a ranking. The other one is something called the peace index. And I tried to graph them out. And I think you can agree with me, this was a failed study. All right. It's a negative study, still deserves to be published. So I didn't find a correlation between the two. And what that says to me is that, maybe my data was wrong, maybe my methods were wrong, but maybe it's more complicated than that. Maybe it's not just about conflict, and maybe this is a much more involved thing, and that it's multifactorial, as I said. All right, so that was a little aside, and it sort of kept me busy for a few evenings while my wife watched Chicago Med. All right, so some more data. Okay, so I want to start with this very useful publication called The State of the World's Children. If you've never discovered it, it's a mine of information, and UNICEF's been putting this out since 1980 every year, which is the year that I matriculated. But this is the 2023 one. And the reason I chose this is it's got a whole section in it on zero-dose children. So there's also a very useful background paper to the 23 report by Victoria et al. I've referenced it there. And if you want to dive into the detail, that's got a lot more detail in it. But in this press release, when they released the 23 report, they make the points that estimated 12.7 million under-immunized, so this isn't zero dose, under-immunized children in Africa, just in Africa, 12.7 under-immunized. And they highlight the impact of COVID, and they put the global figure at about 20%. They link the problem to the reappearance of diseases like cholera, measles, and polio. So that was when they released the report. Okay, here's another busy slide, which requires explanation, but it does have some important take-home messages, so just bear with me. So if you look at on the left-hand side graph, they've divided it into lower income countries middle income countries and higher income countries. If you look at the top line, which is the lower income countries, the overall percentage of zero-dose children in 2023 was about 18%. Okay, but if you then drill down and you look at that in terms of wealth, that 18% overall was 7% in the wealthiest decile in those low-income countries and 30% in the poorest. So it's 4 times higher in the poorest decile as in the richest decile. And if you split it by rural and urban in those low-income countries, it was twice as high in the rural as in the low income as in the urban. You see that effect in the low middle income countries as well, and the high income, but much less pronounced. So the take-home message from that is that if you're a rural child in a poorest decile in a low income country, you are at highest risk of being a zero-dose child. Okay, so there's some risk factors we can pick out there. And on the right, they've done something similar, but instead of using the lower, middle, and higher income, they've used the UNICEF program region rather than income. And the message there is that in Africa, there's also this big inequity or disparity between high income, low income, and between rural and urban. Okay, so I think that's important to note. This is just, instead of those regions, they've used individual countries, and I've highlighted the ones which are in Africa. But if you just take one example there, if you look at the DRC, children in the poorest decile have 10 times higher risk of being zero dose than children in the wealthiest decile, and children in rural settings have twice the risk that children in urban settings have, just for the DRC, and you can look at the other countries as well. The other thing to note about this one is that these are the 10 countries with the largest inequities worldwide, and 7 of them are in Africa on the left and 8 on the right. And South Africa, which is often held up worldwide as being a country with remarkable inequity as measured by the Gini coefficient or whatever you want to use. But I think this says to me that it's not just South Africa. The problem is continental. Inequity is a systemic problem in Africa. And I think that's what Prof. Ridzani was telling us the other day. Remember what he said? Quotable quote, if you don't have money, you die. That's what he said. All right. Other factors. So this is about the mother's level of education. If the mom's got a primary education, she's got half the risk of, or her kids have got half the risk of the children of a child, of a mom who's got no education, no formal education. And if she's got a secondary education, she's got half, it's half again. Okay, so maternal education appears to be very important, predictive factor. This one is about the same data, but it's looking at it by UNICEF region. And you can see that effect is also pronounced, particularly in West and Central Africa. So maternal education seems to be important. And this one looked at women's empowerment, and it used an index called the SWPER, which is the Survey-Based Women's Empowerment Index, about which I'm not an authority, but I'm sure Elizabeth is, so we can ask her. But basically the message is that it's a powerful predictor of zero-dose status in most countries. I think it's important to look at the relative difference, not just the absolute difference. So even in the bottom there, the Tanzania, the actual levels are quite low, but it's a big effect going from no empowerment to some empowerment to high empowerment. Okay. This is the difference between the strata of maternal education. Oh, sorry, did I go the wrong way there? Okay, here we go. Okay, campaigns. So campaigns and zero-dose children, they kind of go hand in hand. And I think most of us, if we hear about a particular community or an area where there's a lot of ZDCs, our knee-jerk reaction is to go and do a campaign because we want to go and protect these children, and that's understandable. There's nothing wrong with campaigns. I'm not knocking campaigns, but I think 2 points. One is that campaigns, it's fine to do it, but you should use the opportunity to also connect with the community there and try and understand what the problem is from their point of view. So if you don't do that, it's a wasted opportunity. And the other thing is, I've said here that doing a campaign is a little bit like putting a bandage or Band-Aid on a malignant ulcer, okay, if you excuse the expression. But it has short and medium-term benefits, but it doesn't actually remove the problem. So you've got to get to the root of the problem and stop the children falling through the cracks in the first place. You can't just fix it by doing a campaign. Technology, I think we saw in COVID, technological advancement in the world is often seen as the preserve of the rich. It's designed for the rich. The rich get first access to it, and then the poor get later access to it. And in the meantime, the poor child living in Africa is actually in greater need of technological advancements than somebody living in the United States. So something like if we could make all of our vaccines heat stable up to 40, 45 degrees, what a difference that would make in our immunization programs in Africa. Or if all of our vaccines didn't need to be given by injection, you could give them orally or sniffing up the nose or something like that. These sort of technological advancements would have huge impact and would actually start to address some of the inequity that we see in our country. But unfortunately, the R&D that's done is targeted to help people who can afford it and from whom a profit can be made. And so the diseases of the poor and the so-called orphan diseases are often just neglected. All right, so here's a paper by Wigley and colleagues, which has got some interesting stuff, which I just want to highlight. So this is a 2022 paper. And it's looking particularly at the urban-rural divide, and it divides the rural into remote rural and non-remote rural. But overall, of the children, oops, sorry, I've lost my place now. There we go. Okay, there we go. Overall, of the children who were unvaccinated for DTP1, 11% in remote rural, 28% in urban and peri-urban areas, which means the other 60% were in what they call non-remote rural. And that's important, we'll see later on. 40% within 1 hour of the nearest town, which sounds, but the flip side of that is 60% were more than an hour from the nearest town, okay? And then about 10% in conflict areas. So we'll talk about conflict as well. So here's some interesting maps, but they also require explanation. So this one, if you go first to the map on the right, which has the red colors, so this is looking at all of the under ones in Africa, the proportion of children under 1 who were 0 dose. So they didn't have their first dose of DTP. Okay, and the darker the color, the higher the proportion. So if it's dark red, it's over 80%. All right. That's on the right. So if you go over to the left, they've restricted the sample from all under ones to the under ones who were just living in the remote rural areas and looked at the proportion of those children who were 0 dose. And you can see that they are much worse off than the ones in general. All right, so just highlighting that as a risk factor. This one is focusing in on the conflict areas, so it highlights the conflict affected zones. If it's gray, it means it didn't meet the criteria for a conflict zone. It doesn't mean there's no conflict there, but it just hasn't been above the bar there. So the gray areas are considered non-conflict area. The darker the shade of red, the higher the proportion of under ones unvaccinated. And I know some of you come from these countries and you can probably identify, because this is analyzed not by country, but by these geographic areas within countries. And you can probably say, yeah, I can see that dark red there was a problem area. Okay. This one, I think, demonstrates quite well the sort of heterogeneity that there is amongst African countries. So what what they've done here is list them all, and they've given you, of the zero-dose children, the percentage that were in urban, peri-urban, non-remote rural, and remote rural. And there's quite interesting differences. So if you look at South Africa and Egypt, a lot of the children were in urban areas. Whereas if you look at, I think it's Mauritania and Madagascar, the vast majority of the children were in rural areas. And then there's a spread between the two of those. Okay. This is the setting, this figure maps the setting where the greatest number of unvaccinated under ones were found in urban, peri-urban. So it's a sort of conglomerate of the others. And I think the useful point it makes is that different countries have different patterns. So if you look at my country, down at the bottom there's areas of my country, like up the West Coast and in the Northern Cape, where most of the ZDC children would be found in rural areas. But around Cape Town, right down the bottom there, you can see the blue. Actually, if we want to target zero-dose children, we'd be looking at the city itself and the peri-urban areas, because that's where they are. All right. Okay, so that's lots of figures, and I'm sorry if it's given you a bit of indigestion, but it's there, and you can go back and interrogate it. I wanted to highlight this because I just thought it was an excellent resource if you're going to do any sort of community education or go through this with your staff or whatever. UNICEF has, as part of that publication, some really nice case studies. They're very well illustrated. There's a nice narrative that runs with it, and it just makes it more real, and it puts a face on ZDC. ZDC sounds like a very dry concept, but remember, behind every ZDC, there's a child who looks like that. Lots of really fine photography, and not just of the moms and the babies, but also of the health workers and what they're trying to do to address it. So just to commend that to you, I'm not going to talk about it. Okay, so what I did, it was just, so it's 8:32 now. I went through looking for papers from Africa, which specifically highlight the problem of ZDC. And I want to quickly just take you through these and show you what they found. Okay, so here's one. This is a scoping review looking at the biggest barriers to vaccination, intent to vaccinate, community access, health service access, poverty, maternal literacy, and education. And these are things which will come up again. This one, this is a review actually looked at the methods used in costing studies that assessed interventions to reach zero-dose children. And what I found interesting was the huge variation in the cost per intervention. So it's 8 cents for an SMS, but if you're going to do cash transfers, it's $67. So quite a big range there. This study was a narrative review looking at potential interventions within and outside of the health sector to reduce zero-dose children, highlighted 3 predominant themes for interventions: community engagement, health system strengthening and integration, it'll make Adina's heart warm, and technological innovations. But importantly, they make the point that no one intervention is sufficient. This is a study looking specifically at children with disabilities. No one tends to forget about them, who are at even higher risk of being ZDC and under-immunized. So they list a number of barriers there: healthcare infrastructure, provider training, follow-up services, stigma, misconceptions around disability and vaccines, and strategies that they suggest: mobile units, tailored interventions, school-based programs, and community engagement about stigma. So that's about disabled kids. This is from Mahaki and colleagues. They did a scoping review looking at recent literature on risk factors and interventions for zero and missed dose children in Nigeria. So this was specific for Nigeria. And they found that factors influencing childhood uptake, maternal education, access to antenatal care, access to perinatal care, community heterogeneity with regard to location, region, wealth, religion, composition, access to vaccination, the facilities, and awareness about immunization safety, efficacy, and importance and schedules. All right. This one looks at who knows what the Sahel region is? I had to look it up. All right, I'm sure some of you do. But the broad band that runs just below the Sahara Desert from the one side of the continent to the other is called the I don't know, how do you pronounce it? Sahel? Sahel? All right. It's that band of countries. But anyway, they looked at the impact of conflict up there in this band of countries, and they specifically looked at Burkina Faso, Chad, Mali, Niger, and Sudan, and then they came up with estimates of the numbers up there. So obviously making the point that they are high, and there's a link with conflict. This is a systematic review, looked at predictors of low basic vaccination in Nigeria again, and they found them to be things like poorest households, Fulani ethnicity. I don't know much about that, but maybe Elizabeth can help us. Born in home settings, young mothers, no formal education, no antenatal care. Okay, this is a scoping review by Sharma, and they looked at the private sector. So how involved is the private sector in trying to address this problem? And they found that the involvement of the private sector ranged from 3% to over 60%. They recommend stronger private sector engagement to reach zero-dose children. And that didn't kind of come intuitively to me. I've never really thought of engaging the private sector to try and get to zero-dose children, because in your mind you think, well, zero-dose children come from very poor families. They don't access the private sector, but they do access the private sector. So we can and we should be trying to get them to help us. And in a similar vein, this study looked at whether colleagues in the informal health sector, and specifically patent medicine vendors, okay, again, not a term that I was that familiar with from South Africa, but patent medicine vendors are apparently very important in countries such as Nigeria, Ethiopia, Tanzania, and the DRC, where there are an important informal health sector link, all right? So they could be engaged to help us, and I'm not aware of examples, but maybe you do. This study looked at predictors, prevalence and predictors of ZDC in Ethiopia. Overall prevalence of 34%, very high. Highest in developing communities, pastoralists, internally displaced people, newly formed regions, conflict-affected areas, and as in other studies, things like wealth index, single marital status, maternal age, and interesting, one of the recommendations was that they needed to have immunization sessions in the evenings and immunizations on the weekends, particularly around the cities. All right, this study did something similar in Kenya, included, along with the usual risk factors, like no antenatal visits, maternal education level, wealth index, religion, place of delivery, travel time to the nearest facility. Some social indicators were included here, which were interesting. Things like listening to the radio, mother's mobile phone ownership, mother's phone use for financial transactions, and they recommended targeted initiatives to try and address this. And then this, I think this is the last one, our paper by our old friend Charles and his colleagues. They found a wide range of ZDC prevalence estimates from 0.4% to over 40%, and similar risk factors, community literacy, maternal empowerment, lack of decision-making power, media access, etc. All right, so lots there. And again, my apologies if it gave you indigestion. It was just a smorgasbord of some of the literature from Africa. And what I want to do then is to get onto how we can use that and everything else we know to try and work out what to do about it. All right. But before I get there, I need to tell you about the African Immunization Agenda and the Declaration of Addis. All right. So here we go. So the AIA, African Immunization Agenda, refers to the commitment by African nations to improve and expand immunization programs, primarily guided by the global agenda, the 2030 agenda, and the Addis Declaration. So the two went into the one. And there you can see as a background all the signatures, all right? So you're still thinking about who didn't sign, all right? Well, one of the focus areas of the agenda is addressing ZDCs. And the declaration itself doesn't actually use the word ZDCs, but if you look at the substance of the declaration, just about everything that it says is going towards trying to reach ZDCs and under-immunized children. All right, so the countries that didn't sign, South Africa, Zimbabwe, Djibouti, Angola, Cameroon, Eritrea, Morocco, Niger, Senegal, 9 of them. And if you delve into it, it's not that they were opposed to it, it's just that for some reason they didn't sign on the day. All right. Okay. All right. So this is how we're doing. Okay, we're just about there. So how do we ensure that no child is left behind? What are we going to do about it? So what I tried to do here was to go through all of that and just to try and pull out, the themes and put them into boxes. In public health, we love putting things into boxes and hanging things on pegs. So that's what I've done here. So in this slide, there's 2 slides. We have community marginalization. What do we do about that? Conflict, service scarcity, socioeconomic barriers, including poverty. Poverty is so important, it's got its own box. Infrastructure problems, ZDC hotspots, so which countries have got the most kids and should we just go for them? Health system strengthening for Edina. And on the second slide, community fragility. What does that mean? Misinformation, health budget shrinkage. And I suppose with that should go donor budget shrinkage, outbreaks, climate change, we haven't talked about, data quality. Do we actually have the data to inform the decisions we make about ZDCs, technology, and then vaccine costs in the hotspots? So is there something we could do about where the problem is worst, bringing down the costs, even if we can't do it for the whole continent? So those are what I've called potential targets. And the question is, which of these can we realize? So can we actually do anything about conflict? Other people can, maybe we can't. Okay. But there are things there that we can do things about. And then do we have the resources to do it? Do we have the time to do it? And who must do it? Who gets the job of fixing the ZDC problem? All right. So that's basically it. Greg said, I have to tell you about the Gavi ZIP initiative, which is aimed at addressing this in specific countries. So you can see the countries there. And I do have some slides on the Gavi ZIP initiative, and I was thinking about it last night, and I'm sure there are people here, some of you must have been involved in the ZIP initiative, and it would be far better if you could tell us about what it meant in your country, how it's been going, and what difference it's making. All right. So I can leave that slide up there and you can come back to it, but there's lots of material on the internet on the Gavi site about the ZIP initiative. All right. And that's basically me, and I think I'm in time.
Thank you, Tony. You're always great with time. Thank you. That was very informative. Lots of content. We're going to take questions from the floor. So just put up your hand. Okay.
Just remember, you're the experts, not me.
Thank you, Doctor, for the presentation. It was interesting to look at when you compare in women with education and also income and empowered women. Like the higher women are empowered, the lower the zero dose incidence. And also the higher women are educated, the lower zero dose. So I was wondering if you also looked at the number of children per women in those categories, because I was thinking maybe the more they are empowered, the higher education they have, the lower the number of children they have. So maybe, I don't know if that can also have a sort of explanation on the results.
Okay, so this must be you must be an epidemiologist.
Yes, I am.
So he's pointing out the possible confounder there. So we've said that maternal education is associated with ZDC proportion, and we've said that maternal empowerment, and he's saying that there might be a confounder in that fertility is related to both maternal education and to the number of zero-dose children, and that might be confounding the relationship, which is probably true. Okay. But let me throw it back at you. So what do we do about maternal empowerment in Africa? women's empowerment in Africa. Ramonda is dying to say something.
I did your Tony. I was actually gonna maybe add an angle onto the previous comment, which was just that I think these things are very hard to look at in isolation. And I think so, I speak under correction, but like in some countries, where, for example, Malawi, where there actually was a restriction on free maternal care and access, depending on how many children you have, that actually has a big impact directly because of the costs. And I think it also just comes down to costs. Sorry, I'm not answering your comment. I'm just adding more.
Thank you so much. Thank you for the presentation. I think I want to add also, it's not just how many children the woman has, is how many households that have polygamous and monogamous households. That's also have an effect on immunization as well, at least in my country. So the other thing that when you, in the presentation, it shows how South Sudan is doing relatively well, even though we have conflict in our country, and you were mentioning that. We just need to look at the picture in South Sudan. I don't know which this data is coming from which year, because since 2023, we have an influx of migration from Sudan. Those people are being part of the community, and because of equity, they are receiving vaccine. But when we are coming to our performance, we cannot differentiate which vaccines, which number of people who migrated to the country received vaccines, and which number of those are host community who received the vaccine. So you find we have a very relatively good coverage, but the actual sense is that most of those people who received the vaccine either migrated communities, because they tend to take the services to them. So they are highly serviced. So you get that the host community is not serviced. And up to now, we don't have census. I think the last census done was 2008. We are working on projecting our population each year with this 3% growth rate, but we don't consider other aspects of, when we do the projecting, is not actually accurate. So up to now, we have issues in population to use our denominators in determining our coverages and so forth. So I think for us, we have issues. I want to comment. It looks like we do very good, but we are not. We still have high zero dose, and we do have a ZIP project run by IRC in South Sudan. It's also supported by Gavi. It shows that we did a joint appraisal recently in last month in October. We were looking at Gavi project 5.0 going to 6.0, and this is one of the issues that it looks that we are doing very good, but the data is not separated. Who's migrated it? We have numbers like in 2023, it shows that 800,000 people migrated from Sudan to South Sudan. And this is just from points of entry that is being monitored. We know in South Sudan, we share a lot of borders with Sudan, and some of them are not monitored or being controlled. So yeah, thank you.
So I think that's a very important point, is that often these are moving targets. It's one thing to have targets, but the targets move all the time. The goalposts move. The references, so the Wiggly paper was a 2022. That's where a lot of those maps came from. 2022 publication, and it takes a while to publish. So that's probably 2020 data. The graphs that I showed you at the start are from the 2024 IA 2030 progress report. And again, so if it's 2024, the data is probably 2023. So these things do change, and they often just change overnight. So yeah, moving targets.
Thanks, Tony. We're going to only take 2 more questions. One's going to be from online, and then there's already a mic on that side of the room. so online.
Thanks for a great talk, Tony. We have a question from Morongwa. She's asking, how is cross-border collaboration being managed to ensure children moving between regions or countries are not missed?
So, okay, so I don't know if you all heard that. So cross-border issues and cross-border collaboration. There might be others who can speak more authoritatively to that than I can. I can tell you that, I mean, borders are not all national borders. So even within a country, cross-provincial borders can be an issue. And where we would like to be, certainly in my country, is where there's just one health record, preferably electronic, where a child who is born in Cape Town and then migrates to the Eastern Cape and ends up in Limpopo or so on, when that child's taken to the clinic, the nurse, the doctor, anyone else who's seeing it will be able to see not just what has happened in Limpopo, but what happened in the Eastern Cape and what happened in the Western Cape as well. And that's part of the big vision of national health insurance, which you may have heard about in South Africa. I'm not sure what's happening in other countries. I know that this is a big challenge even in high-income countries. And then when you start talking about cross-national borders, then you really are, I don't think there's any two countries in Africa where they sort of share health departments and share health records and share databases. So what we need to move to is a common African Union where everybody's on the same page, but not in my lifetime.
Okay, last question.
Thanks for the presentation. My question is related also to the maternal education and risk of ZDC, and whether that's just an indication of lack of health education, or is maternal education actually a proxy for socioeconomic status? And the reason why I ask that is, if you have limited resources and you have to target your intervention, do you pitch it? I know it's a combination, but I mean, if you only had limited resources, do you target at just health education, or actually you should target at improving people's socioeconomic status, and in that way that will indirectly increase?
Yeah, so another good question. I think there's good evidence, and Greg can back me up maybe. Improving maternal empowerment and maternal education isn't just good for, reducing the number of zero-dose children. It has huge benefits across the sort of public health spectrum. So I would always say it's always worth investing in women's empowerment and women's education, the girl child, all of that. But I'm not basing that on evidence, which in this forum is probably risky. Is there anyone who can speak to that? Ben, Greg? No? Do you agree? No? Education overall, yeah. Yeah. But your point is, again, might be confounded. Which do you focus on? We've all got limited resources. If we can only address one or two factors out of all of those ones that I put up there, which ones are they going to be? And it won't be one size fits all. It'll be a different one in South Africa to Egypt to Mauritania or whatever. Okay, so I'll leave you with one thought from Greg, which was, he told me the other day, the issue is not how many ZDCs we have. The issue is that we have ZDCs. There should be no ZDCs in our continent. Thanks.
Thank you, Tony. That was a great start to the day. And yeah, I agree. There should be no ZDCs. We're going to switch things up now. And we're not actually having Bev speaking now. We're going to have Dr. Albie de Vrij, who is the president of the South African Society of Travel Medicine. And he's going to be speaking on targeted vaccination for travelers. And I've heard Dr. de Vrij before. You are in for a treat. He's one of the most interesting, entertaining speakers I've ever heard.
Thank you very much. Good morning, bonjour, buongiorno, bom dia. Is there anybody here from Equatorial Guinea? Speak Spanish. I had to look up the Spanish. Thank you very much to Prof. Ben and the ladies that arranged everything for inviting me again. So you've had lots of science this week so far, so now you're in for a little bit of edutainment. They don't really get me in because of the science. And thank you very much to Dr. Bev for swapping spaces with me. It's all about catching a plane this afternoon. It was going to be just a little bit tight with Cape Town's traffic. In Johannesburg, the drivers are terrible. And the roads are terrible. Here, it's just the drivers are very terrible. The roads are okay. Yes, Anthony, where's he now? I'm one of the thems. You know, we were talking just now about the public health and them in the private sector. So I'm from the private sector, so it's completely different. But let's talk about that. So I'm supposed to talk about targeted vaccination. So I'm going to give you a travel medicine lecture in a nutshell. It's not just about the vaccines, it's vaccines for all, really. So that's just a quick overview of what we're going to talk about. So I'm going to introduce you to the concept of travel medicine. So let's just first quickly say something about who is a traveler. Anybody wants to put up a hand? Who's a traveler? Mention travelers. Everybody's travelers. Business travelers, holiday travelers. You guys are travelers for academic reasons, okay? Who else is a traveler? Those rich oaks with the 4x4s going up north to Kenya. And we talked about them just now. The migrants, the cross-borders, people, refugees, asylum seekers, they're all travelers. So it's not, travel clinics are not just for rich people with 4x4s going somewhere or for business travelers going to New York, heaven forbid, or whatever. So this is just a formal definition of travel medicine. It's a multidisciplinary part of medicine, of which the primary goal is to prevent illness and injury in all types of travelers. And education is 95% of that. If I give you every vaccine in the book, every vaccine I have in my clinic, I can only protect you against 5% of the diseases, the infectious diseases that you may contract when you're traveling. The secondary goal is to teach our travelers when they get sick, if something happens to them, the one big infectious disease, the biggest infectious disease killer in Africa of travelers is malaria. Okay. I still can't vaccinate a traveler against malaria. It's all about education. Don't get bitten, seek early treatment, take the pill. Okay. So we want to teach them, if you've got a flu-like illness, what are you going to do? You've got to think about malaria. You've got to make sure that you get tested. Either you test yourself with a rapid test, which is a little bit controversial, but it really saves lives. Or you've got to get to a reliable doctor that's going to make a reliable diagnosis and give you early effective treatment. And then over the years of doing travel medicine, which is about 30 now, we've added a concern to the impact of travelers on the host country. So if travelers with an infectious disease go to a country, let's say I've just started, well, COVID was the big example, but let's say I've never been vaccinated against measles. I feel a little bit ill. I leave Joburg and I go down to Mozambique, and I go into a community where the kids have not been vaccinated, all those zero-dose children that we were talking about just now. I can take measles to the host country. Okay, so we don't want to do that either. But this is my definition. It's what you bite into, what bites into you, and what hits you. What you bite into, okay, not a good idea to eat snails undercooked somewhere on the street. Bushmeat may be a problem. God's gift to travelers is bananas, because you can peel those bananas. That's the Central African Republic. You can peel a banana and eat the inside without contaminating the banana. So you're not going to get traveler's diarrhea. You're not going to get hepatitis A or cholera from eating a banana. Then things that bite into you, that's a little bit extreme. And then there are things that hit you. So road traffic accidents and interpersonal violence. We talked a lot about that. I'm not discriminating. There's something for the ladies as well. And then I absolutely couldn't resist adding these guys. We've got some heroes. And this is our latest hero. This hero is probably the biggest disaster to public health in our lifetime, what he's doing along with Robert Kennedy. I then asked AI to change that gun into a syringe, and it reported an error message. Okay. If we make it a little bit more formal, you bite into it. So traveler's diarrhea, hepatitis A, typhoid, Lassa fever, cholera, that's all food and waterborne disease, okay? And some of it is just going to upset your trip. 30 to 80% of travelers to developing countries will develop traveler's diarrhea, but some of it, like hepatitis A, can get you sick for 6 weeks. And if you're older or debilitated or pregnant, you can actually die from something like hepatitis A. And of course, that is vaccine preventable. Then it bites into you. So things like mosquitoes, malaria right at the top, yellow fever is also mosquito borne. Then rabies, ladies of the night, men of the night as well. Sleeping sickness, tsetse flies, dengue, again, the mosquitoes, river blindness, little black flies. And then we've talked about the trauma things. So where did the idea of travel medicine come from? Well, in round about the 1980s, the Swissies were like this. They were all beautifully immunized, all packaged in neat little boxes, and they had lots of money because they were storing other people's money. They were like a castle in the Alps, okay? And they had money, so they went traveling to developing countries. And Professor Robert Stephan, who was the father of travel medicine, picked up that these Swiss travelers were going out to Thailand, to South America, and coming back with infectious diseases, and some of that was vaccine preventable. So that's where the idea started, that if you go traveling, you need a travel vaccine. So I want you to just park this idea a little bit, and then we'll talk further about it. So that was really the idea, that we could protect travelers against infectious disease by vaccinating. So let's think a little bit about that. So this statement, travel health practitioners are dependent on public health practitioners for epidemiological data regarding disease risks and vaccine coverage to make good so-called evidence-based recommendations to travelers. So this is a rural clinic in Liberia. I went there with a bunch of geologists. And so by going there, I could get an idea of what was going on in that area where my geologists were going to work. And so I could decide what am I going to try and protect them against, malaria right at the top and some of the vaccine preventable diseases. At the same time, if one of those geologists comes back ill, and I'm picking up that he's got, so let's use an example. There's a game park in the far north of the Congo called Garamba. It's very, very remote. They do some wonderful work protecting the rhinos, etc. A couple of weeks ago, we had a British lady who works there who reported that she's been ill for about 10 days. She's got fever. She's got a flu-like illness, fever, headache. She's got a rash, and she sent us pictures of her wrists that were swollen like this. And she was treated by the local doctors with adrenaline infusions that would make the rash go away for about half an hour, and then it would come back again. So after about a week, I got involved. I was hurtful. I said, get on a plane and come home. What was their diagnosis? PCR positive, chikungunya. Okay. Now, they don't have the means in that part of Congo to diagnose chikungunya because they don't have fancy laboratories. So we could now confirm there's chikungunya up there. So that's a traveler acting as a sentinel of diseases happening somewhere. So it's really a cooperative, and this is one of my themes. There's no us and them. We're all on the same planet, we're all on the same boat, and we really need to work together to make these things work. So if I go and look at the WHO website and I see there's a measles outbreak in the DRC, then I'm thinking my travelers should be vaccinated against measles when they go there. But of course, this is a fairly old slide, and then we can come and look on our own home ground. So I want to know, if we can write all these nice articles about zero-dose children, if we can find the zero-dose children for those articles, why can't we freaking find them to vaccinate them? Okay? Should we work a little bit harder at that as well? So we can see that there's measles in our own country. A few years ago, we were reporting, I think, 900 cases, and now we're up to 960 cases, and now we're up to 1,300 cases. So this is not new to anybody now. Measles is going haywire. We know why that is. The reproductive number is 18. It's one of the most infectious diseases. And the concern is not really the measles. It's what's going to follow the measles. It's all the other childhood diseases, because if we're not covering measles, we're also not covering diphtheria, pertussis, and all the others. So we look at the public health data to decide what we need to vaccinate our travelers against. Now, East African trypanosomiasis, I can't vaccinate you against, but in the period 2018 to 2019, we had cases from Uganda, Malawi, and Zambia. And just this year, in September last year, we had 2 cases from Zimbabwe. And in 25 now, this year, we've had 2 cases from Zambia, from the South Luangwa Valley. That's just up in Joburg. Now, part of the problem with this is I don't know how many cases were seen in Cape Town this year, because we don't have a good central database for reporting on these diseases. We're not going to have a vaccine against trypanosomiasis very soon, I think. But an up-and-coming disease that I'm very concerned about is dengue. And unless we can report on our travelers coming back from anywhere in the world, but out of the rest of Africa, South Sudan, where's the lady? Okay. We look after a group of people there, and on a regular basis, they've been reporting. They go to a certain clinic in Juba, and men and women all get diagnosed. If it's not malaria, it's bladder infections. Men don't get bladder infections. Okay. And then the other day, I saw a report coming through from ProMed. There's a huge outbreak of dengue going on in South Sudan. Okay, so that's what they have, because a lot of them, along with their bladder infections, have also had a rash. Okay, but there's no laboratory facilities to pick that up, so we don't know. And we want to know about those dengue cases, because if we want to tell the vaccine companies that we want a dengue vaccine, we've got to prove to them that there's a market for a dengue vaccine. If we don't have that data, we're never going to get the vaccine. Right, this is just West African trypanosomiasis. This was an exciting case. It was diagnosed down here in Cape Town in a diplomat. Okay, so in travel health, we're always looking at a balance between the traveler's own health and a public health requirement. And where's that very important when it comes to vaccine preventable disease? We'll jump onto that one in a moment. Okay, so some of these diseases that we talked about are vaccine preventable. We've already said doesn't cover malaria. It does cover COVID, or it did cover COVID. And what's our dilemma in South Africa now? We don't have COVID vaccine. Who's got COVID vaccine available in their countries? Where are you from? Togo. Yes, so Togo's got COVID vaccine. I was in a mine hospital in Tanzania the other day. They had COVID vaccine in the fridge. Egypt, you've got COVID vaccine. We don't have COVID vaccine. I want to be able to vaccinate my, where are you from, sir? Benin. You see, there's all these little backward developing countries. They've got COVID vaccine, but wonderful South Africa, we don't have COVID vaccine. Do we still have vulnerable people that should get a COVID vaccine? Yes. Are they travelers? Not necessarily. Okay, but we don't have COVID vaccine. So let's talk about it. So there's no more COVID vaccine on this side. Okay, so where do we begin with the travel vaccines? Well, the first thing we ask a traveler is, have you had all your childhood vaccines? There's no point in thinking about exotic vaccines when the guy is not up to date with what's supposed to be, should have been covered by his EPI. So we're not going to give him a BCG if he didn't have one at birth, but the DTP, polio, Hep B, etc., etc. Now, we'll talk about the childhood vaccines in a moment. And then there's the so-called compulsory vaccines. Yellow fever and meningococcal disease is really the only two now. COVID used to be there. And then there's the so-called travel vaccines. So this is also just important to realize, if you're looking at a traveler, not all EPIs are equal, and you guys know that better than I do. So we can see right at the top there is the WHO recommendation from a few years ago. Then there's the South African EPI, and then there's the American EPI before Robert Kennedy got in there. Okay, so again, a little bit back to the richer the country is, the better the vaccine program, and the better covered the people are that are maybe less vulnerable than the poorer people. But that's not completely true, because if you live in a yellow fever affected country, and just Angola jumps to mind, then yellow fever vaccine, that's a so-called travel vaccine, may be covered by the EPI or should be covered by the EPI. And the same thing when we had the rugby in Japan, people said Japanese encephalitis, never heard of Japanese encephalitis. Well, on the North Island of Japan, where they do have Japanese encephalitis, the kids are vaccinated. That's why the locals aren't getting it. But if you're unlucky enough as a traveler to go there, get bitten by a mosquito, you could get Japanese encephalitis. But there, it's certainly not a travel vaccine. We don't have it available here anyway. It's not a travel vaccine. It's part of the EPI vaccine. So there are holes in this idea of travel vaccines and EPI vaccines and compulsory vaccines. Okay, so let's just move on to that. And that's also just to demonstrate there's the Botswana EPI schedule, and there's the South African one on the far right, and then there's the Australian one. So what's a big difference there? The Australians don't get BCG at birth, okay, because they've got a very, very, very low incidence of tuberculosis in the country, and so they don't get BCG. That doesn't mean if I've got an Australian mine worker coming to work in Africa that I'm going to give him a BCG. In fact, it's a bad idea. So a couple of years ago in Gabon, a guy got hauled out of the queue at the airport, and he was given a yellow fever vaccine by airport authorities, which of course is not in line with international health regulations. And then the mine manager decided he's never going to let this happen again. So he told the medic on the mine to take all the mine workers, locals and international people, to the local hospital and let them get every vaccine in the book. So we had an outbreak of lumps and ulcers on the forearms of these guys, and the one ulcerated. And why was that? It's because they were giving them BCG. And in Gabon, they give BCG on the forearm. So the local guy that had been exposed to TB before had this huge ulcer developing. And it wasn't a disease, it was because of the vaccine. So you don't let the mine manager decide about it. So let's talk about yellow fever. I'm not going to lecture you on yellow fever. You all know what it is. But it's the only compulsory travel vaccine in accordance with the international health regulations as per the WHO. And that it is there as a public health measure to prevent the spread of yellow fever from yellow fever affected areas, sub-Saharan Africa and South America, to other parts of the world where the mosquito, the vector is present, but where the disease isn't present at the moment. And when we had the outbreak in Angola a few years ago, there was a big scare because there's lots of Chinese people working in Angola. A couple of them were there with fraudulent yellow fever certificates, and about 10 of them went back to China and they were diagnosed there with yellow fever. Now, if they got bitten by mosquitoes in China, then we're going to have yellow fever being introduced to the Chinese population that is huge, and that's what the IHR is all about. So if we talk about a yellow fever vaccine for a traveler, we've got to look at where is he going? Is yellow fever present there? We want to protect him against yellow fever, and we want to prevent him bringing the virus back to us because we also have Aedes aegypti in this country, and so it could spread down here. So airport checks takes place. This was a couple of years ago in Zambia. You couldn't board the plane from there. Now there's no more yellow fever in Zambia for now. There was for a little while, and then it went away again. So there's some politics involved in this as well. But there are about 150,000 cases per year and maybe 50,000 deaths a year, not well recorded. Lots of people in Africa will be diagnosed with malaria. They'll get treated for malaria. They'll probably get better. And like a lot of viral diseases, the majority of people who get yellow fever are not going to die from it. It's a small percentage. So the diagnosis very often gets missed. It's a live vaccine. There's a South African that got the Nobel Prize for it in the 1950s for developing this vaccine. So it's still the same vaccine basically being used, but it's got certain indications and contraindications. And that's why in this country, at least, the clinics need to be licensed to give a yellow fever vaccine. So that's just the areas in the world where it occurs. We don't have too much time to go into it in detail, but you can see it's in South America and in Africa. And the reason, if you go and look in the Bible, depending on which one you read, but it says in the beginning there was yellow fever in Africa. But it's after Eve fiddled with that apple that it spread over to South America. And that's how we know it's the big travel disease that spread with travelers. It spread with the slave ships. And that's how it got introduced into South America. And that's why we're concerned about it spreading to other parts of the world as well. So it's still out there. It still happens. Some people say to me, but I've never heard of anybody getting yellow fever. Why should I be vaccinated? Well, it's out there and it's alive and well. So that's yellow fever. And then meningococcal disease is also, it's in the Sahel. We heard about the Sahel just now. It's that area there. You will get at least 1 mark, Anthony, for your MCQ in the travel medicine exam, because one of the questions was, we talked about the Sahel, and lots of students said, where's the Sahel? So go and check up on it. So obviously it's not compulsory proof of meningococcal vaccination if you're going to the Sahel region. It's for your own protection. But we've heard about the Hajj. So we've got millions of pilgrims going to the Hajj, gathering together in a small area in Mecca. 6 million people living 2 million people living in tents for about 6 weeks. And so we've seen in the past massive outbreaks of meningococcal disease because we carry the bug in our nose. You're not necessarily sick, but if you cough or sneeze over Ahmed, then Ahmed actually gets sick. And the other scary part of it is that the pilgrims sometimes take the bug back to where they come from. We've seen big outbreaks in Indonesia. So the WHO supports the Kingdom of Saudi Arabia's government in saying that all pilgrims must show proof that they've been vaccinated against meningococcal disease. And we know that it's got a huge public health benefit. So that's compulsory. But then, of course, this is the Sahel region. And years ago, we had massive outbreaks in that region. We spoke about it already earlier this week. But in refugee camps like this, or also in internally displaced camps in Liberia, that's not necessarily in the meningitis belt, but that's the other conditions under which we see outbreaks of meningococcal diseases anywhere where people crowd together. It doesn't have to be an internally displaced camp. People who work on mines, police barracks, military barracks, young people getting together, university hostels. So we've got a couple of groups. We've got people in the Sahel, local people coming together around water points in the dry season in the around the wadis, and that's how the meningococcus spreads amongst them. That's now pretty well controlled with the meningococcal vaccine programs that have been instituted. We've people going on the Hajj, and then we've got people in crowded conditions. But the one that is puzzling me more and more is, how do you do a risk assessment? When do you vaccinate somebody? So this year again, a second-year student at one of the local universities was found dead in his room. Nothing wrong with him 2 days before. Next day he was dead. What did he die from? Surprise, surprise, meningococcal meningitis, okay, or meningococcal septicemia. So we should also be vaccinating our first-year students. But if you write to the universities and say, hey, my travel clinic needs money and Sanofi wants to sell vaccines, we suggest you vaccinate all the first-year students. You must send out letters to the parents. They say, no, we can't do that because it'll scare the students off from coming. And then people are surprised when students die from meningococcal disease. So it's that thing. You guys are working with public health, with large numbers. You've got to look at where you're going to spend your money best. I've got to decide, how do I spend this traveler's money best in front of me? And the traveler may just be a student. So if students go overseas, if they're going to study in the UK and the USA, many of the universities and colleges will insist that you show proof of meningococcal vaccination. Okay. Right. So this is the so-called stephanogram. Professor Robert Stephan, the guy I told you about, he worked out that if travelers go to developing countries, approximately 25%, we're just making it easy, it's 30 to 80%. 25% of people who travel to developing countries will get traveler's diarrhea. Remember, it's what we said, it's what you put in your mouth. And about 2.5% in West Africa, one of the highest risk areas, will get malaria. No vaccine, it's education. And then 0.25% will get hepatitis A. So when I started with travel medicine 30 years ago, hepatitis A was the most common vaccine preventable disease. So everybody got a hepatitis A vaccine if they came from Switzerland to Africa. And then over the years, we've adjusted this stephanogram because you've got to keep up with what's happening. And as more and more data became available, you can see good old traveler's diarrhea is still way up there. But I think it was after the 2009 swine flu, suddenly what popped up? Influenza, okay? Influenza is actually the most common vaccine preventable travel-related disease. I'm struck in the last couple of months about how many friends I come across that have traveled to Australia, to America, yes, also to Europe. Just when people travel, they come back with some sort of respiratory thing. And we know in COVID, airports and aeroplanes were terrible things. That's where everybody got COVID. But it's actually still happening. You go out of your area and you pick up somebody else's respiratory thing. So influenza is way out there. Influenza is seasonal in the northern and the southern hemisphere in the temperate climates, but in the tropics. How do the viruses get from London to Joburg? They go through the tropics all the time. So when Koos is going to work on a mine somewhere in Central Africa, it's always a good idea to give him a flu vaccine anyway, and then he won't think he's got flu when he's got malaria. Okay, so dengue now pops up there, and by 2018, the graph looks like this. We've got influenza way up there, malaria is still way up there. We've got hepatitis A, and now for the first time, I don't know whether I can point with this, measles and pertussis. That's childhood vaccines. So what are they doing on the travel vaccines thing now? That's because even then in 2018, before COVID, before Robert Kennedy, these childhood vaccines the childhood diseases started creeping into picking up. And so we know already, this is an old slide, so I'm going to run through it very quickly, but in many different languages, an uptick in measles becoming a problem. I put this in for my travel medicine students because people think of measles as a childhood disease. This is a story of an El Al aerostess that did a flight to New York, large conservative Orthodox Jewish community in the outskirts of New York. She contracted measles as an adult from one of these guys, and she ended up dying on a ventilator a few weeks later. When, like most of the childhood diseases, It's bad in children, but when older people, when adults get it, it very often has disastrous consequences. You all know about the reproductive number, so I'm not going to say too much about that now because I'm getting placards waved at me. So we need to remain up to date with disease patterns. It changes over time, so people who run travel clinics, just like public health officials, must know what's going on outside there. Now, what's wrong with these slides? All the stuff I've been showing you, it comes from Switzerland, okay? So it's European data on European travelers. They've got very good databases of people who go to these exotic places, come back, end up in infectious disease hospitals. And so they can say, if you go to Thailand, you've got a high risk of getting dengue. If you go to West Africa, you've got a high risk of getting malaria. But we don't have statistics for African travelers. Okay, so it's a challenge for all of you. We need to work together to say, but what's the real risk? Of course, in broad terms, they're going to be the same, but we need our own data to be able to make good evidence-based vaccine recommendations. So in a travel clinic, how do we decide who gets what? This simple little mnemonic, DDT, remember the thing that kills mosquitoes, and donors have got all kinds of ideas about, but that's how they got rid of yellow fever out of the southern part of America. That's how they got rid of malaria in Europe. Okay, but now we don't use DDT anymore. There are better things. Okay, but never mind that. So you look at the destination. Where's this traveler going to? And a destination is not just a geographical place on a map. If I see a business traveler going to India, he's going to Mumbai for 3 days for a business conference. He's going to stay in the 7-star Taj Mahal hotel and only drink bottled water, okay? Then his Mumbai is not quite the same as when his 17-year-old daughter comes in the next day. She's going backpacking to find her inner self in India for 7 weeks. Her India is not the same. Okay, she needs different vaccines from him. So the destination, the disease risk, what is there? We need to know. Who is the traveler? What's his chronic medical conditions? What chronic medication is on? What is his acceptance of risk? What's his budget? And so then we look at the cost, and the cost is the cost of getting that disease. If you get rabies, the cost of the disease is a box, okay? You're going to die, okay? So it's got massive, it's less likely to happen, but it's got massive consequences. What is the cost of the vaccine? Which vaccine should I be spending the money on? Do I rather make sure that he's got a DPT polio because he's going to work with animals, he's going to work in the veld, his risk of tetanus is there. We do a good thing for public health by giving him an injectable polio vaccine on top. We know that diphtheria and pertussis is coming back. And then is there a vaccine, and is it a safe vaccine? How effective is it? And how many should he have? Maybe boosters before he goes. So where is he going to do what? That's just some geologist again, the geographical spread of disease. If you go into, it's not the same clinic as just now, but you walk in there and there's a signpost up about Lassa fever, then you know there's real Lassa fever around here. It's not just something you learned about in fourth year medicine. Okay, and we've had 2 South Africans die from Lassa fever from West Africa that was missed. In fact, in the one guy, they thought he had yellow fever, but he ended up having Lassa fever. So we, on all our travelers, apart from looking at their vaccines, we also want to know about their pre-existing diseases, what's unacceptable risk. If you've just started chemotherapy for your colectomy for your colon cancer and your white cell count is 1,000, you can't go and work on a mine in Mali, or you can't go to this exploration site in Konokoido in Sierra Leone. It's just not a good idea. You're too susceptible to risk. And then we decide to vaccinate them. So we've spoken about this. Now, this is becoming more and more important, is vaccine availability. I'm on a mission about all the medication and the vaccines that are disappearing off the South African shelves. And I'm not even talking about the rest of Africa. All of you know that. Essential medicines that are not available. Who takes responsibility for that? And when stuff like malaria pills that used to cost 35 Rand for Olarium is now costing 125 Rand because we have to bring it in Section 21. That's wrong. There's some work for the NHI to do. So we have to fight about the vaccines as well. We've got to have the data to say, but we're going to need a dengue vaccine. We should start thinking about the chikungunya vaccine. And we can't say we don't have hepatitis A vaccine in South Africa because there's no market for it. That's absolute rubbish. Okay, good. We're seeing this more and more, that the population that we're sending travelers to aren't always vaccinated as they should. So things are changing. How do we make a decision on who gets what? We use this sort of graph. It's not exactly science, but what's nice about this one is, do you see that as travelers' risk assessment, and which hepatitis A was right at the top, it's fairly common, it'll have a high impact, so you're going to give them a Hep A vaccine. Measles as a travel vaccine was right at the bottom, but the world has changed completely. And now the first thing you should make sure is, has the guy actually had his measles vaccine? And then you make a decision about it. Just a quick list of all the non-vaccine preventable diseases, and there's lots, all the stuff we need to talk about. We need to talk about travel insurance cover, which has got nothing to do with any of you. So who of you have got travel insurance for coming year? Yes? And the rest of you? What's going to happen if you walk across the road to Cavendish Square and a car runs over you? Is Prof. Greg going to get you admitted to Grote Schuur? You're going to get there and they're going to say, show me your passport. And they're going to say, no, we're not paying for you. You're a foreigner. Travel insurance, extremely important. Please don't travel ever again without it. Okay? You can get into real trouble with it. So we go back to our parking spot. So this was the world of travel vaccines for rich people going to poor countries. And now everything has changed. The whole politics in the world has changed. And we're seeing mass migration taking place like we haven't seen in centuries. And the story goes that these migrants are bringing in infectious diseases. But in fact, there are studies that show the migrants pick up infectious diseases in the asylum centers and in the refugee centers. I'm talking out of the kitchen now, but we were contacted 2 weeks ago in our clinic by a certain country who's going to support 7,000 members of a certain ethnic group in this country to immigrate as refugees to a big country to the west of us. And there's basically no screening. We're just going to rubber stamp them and say, you're going. They want to know about 3 infectious diseases: TB, gonorrhea, and syphilis. And if they have any of that, we treat them and then they go. If these people want vaccines, the receiving government will pay for all the vaccines. But I've got a nasty feeling that most of the people we're going to see have not been vaccinated because they don't believe in those vaccines. Okay. If you formally immigrate there, you must show proof that you've been vaccinating and you've got to pay for it out of pocket. It's just like, it's totally the wrong way around. But it's about migration. Okay. So infectious diseases knows no borders. There's no more castles. We're all in the same global village. One virus, one bacteria affects all of us, and one vaccine protects all of us. Migrants are travelers too. We spoke about all the others. So it's really a matter of vaccines for all. It's not just 5 minutes. It's not just the public sector. Please engage the private sector. In this country, the idea that GPs stock vaccines has been taken away from them completely, because a couple of years ago they decided flu vaccine will only go to the big retail pharmacies. So the GPs lost complete interest in stocking vaccines. It's too much trouble. So now we're losing all those opportunities to catch up on vaccines in the GP practices because it's a public health thing. It's got nothing to do with us. Okay. So if we protect the children, if we vaccinate the small fry, we know we protect the elderly. We give pneumococcal vaccine to babies, we see less admissions in the elderly. If we vaccinate the grandmas, then the kids don't get pertussis before their vaccines kick in, okay? If we protect the travelers, then they don't take the diseases to their country going to, and they also don't bring diseases back. So it's really a matter of, we've got to vaccinate them all. And importantly, right on the end there, if we vaccinate the animals, we also protect the people. If we vaccinate the dogs, the stray dogs against rabies, then we protect the people, okay? If we vaccinate the animals, then we've got food security. Right, so this is, you can't read the fine print there, but we published this a few years ago. It basically says whether you go to Romania, that's fairly exotic, or whether you're going to remain here, it's phonetic, okay? Whether you go to the British Isles or the Blikkies Isles, Pick and Pay around the corner, you should have these vaccines up to date. And that's just all the standard vaccines. There's a new concept in our country. We're talking about lifetime vaccination. Well, we should have had lifetime vaccination a long time ago. We saw that schedule for the Americans. They get vaccinated from the day they're born until they die at 90 or whatever. And here, we're all walking around with the idea that vaccines are for children. So when COVID came, we couldn't understand that adults didn't want to be vaccinated. because they're far older than 12 years old. So why should they get a COVID vaccine? You don't vaccinate adults. Okay. So that was just the message there. We put these out recently to attract attention, sex cells. Okay. So you've got to be older than 18 to read this. Okay. And what it tells you is you really should be up to date with your vaccinations. HPV. I think it's a wonderful vaccine. And we provide HPV vaccine in our travel clinic. Why? Because the GPs don't stock that and the obstetricians don't stock that. And so there's an opportunity when somebody comes to my travel clinic because the travel agent said they must have a yellow fever vaccine. I'm going to say to them, never mind the yellow fever vaccine. Yes, we'll do that. But what about all these other vaccines? Are you up to date? Okay. Right. And then there's Mpox all around Africa. And what happened in this country? We said, ooh, Mpox, sexually transmitted diseases for those guys that grope around in the dark. That's not what it is. In the DRC, it's a household disease. The kids play with the rats. The mothers cook the rats. And that's how Mpox spreads in the village. Now, if I've got mine workers going to work in the DRC on a mine with 6,000 workers, 600 expats, and 5,000 local people, and they're all in a dark tunnel, and Philippe from the village picked up Mpox from his kids because they don't have decent hygiene at home, and now he's in the dark tunnel with my expat. Why should I not want to protect my expat against Mpox? But it's no. It's for targeted groups. So I visited this particular mine. I won't mention names. And this is in the laboratory. And the doctor said to me, oh, those guys are from the government. I said, what are they doing? No, they're testing for Mpox. Okay, they had 21 specimens there from a village 200 kilometers away, but the government clinic doesn't have electricity or reliable electricity. So the mine made their facility available. And the next day I went back and I said, and so what did you find? And there's the 3 positive specimens they had. The lab workers were not vaccinated. The mine lab workers were not vaccinated. And the mine doctors were not vaccinated. So there's the Mpox on the mine that I've been talking about. Okay. And it didn't come from a nightclub somewhere. The CDC recommends Mpox vaccines for travelers to Central and Eastern Africa. Do we have Mpox vaccine? No, we don't. And this is from just 2 or 3 days ago. Mpox in Malawi. We all love Malawi. I lived and worked there for 2.5 years in my young days. There's Mpox all over. Is it all in gay men? No, it's in children and women. Okay, and Mpox was not known in Malawi. So Mpox is going all over Africa quietly, okay, while we sit and sleep. So private-public disconnect. We all live in silos. The private sector doesn't talk to the public sector. The public sector doesn't talk to the private sector. Within the private sector, laboratories don't share what they see. In Johannesburg, I'm trying to say, how much dengue are you seeing? How much chikungunya are you seeing? In this laboratory, yes, we've got 2 or 3 cases. In that laboratory, they've got 1 or 2 cases. But we don't have a central place to put that data in to know about. We don't talk about it. We don't have meetings like this where we can all get together and say, but we've got a common goal. We really all want to improve, really reduce infectious diseases in the world. So one planet, one health, no animal vaccines, no food, rabid dogs, and dead people. It's all interconnected. So a visit to a travel clinic is a public health opportunity in which we can spread the message of getting vaccinated. It's not just for the rich people, and education is the most important thing there, but the vaccine part must not be neglected. Anybody interested and bored, nothing better to do than go and sort out your vaccine programs. If you're interested at all in what I say, the Southern African Society of Travel Medicine publishes these books. The CDC Yellow Book, you must get hold of one while you can. It's available online. And I'm busy helping rewrite one of the chapters on safaris in Africa. Every time we have a Teams meeting, another one of the editorial board in the CDC has been fired. It's scary. It's really scary. So it may not be available for very long anymore. And then apart from the CDC book, you can also go to the WHO. There's a section called International Travel and Health. And you can get the same sort of data there, but it's slightly more public health orientated. The CDC stuff also looks at travelers. I'm leaving some brochures outside. We do a travel medicine course every year in May. May not be really what you want, but if you know about colleagues, people who work for multinational companies, embassies, the United Nations, this is a 5-day course in Joburg. It's in conjunction with the University of the Witwatersrand. Thank you very much, Prof, for the airtime. And we would be very, very happy to see you guys out there. Good, that's the end of my story, and I think I've stuck more or less to something.
Thank you, Dr. De Vrij. I'm going to take one question from this side of the room, one question from that side of the room.
Hello, thanks very much. So my question is about what we do in the case of undocumented migrants, and not those that, because most undocumented migrants do get travel documents and then they overstay. So in that case, they would have gotten yellow fever, meningococcal vaccines, whatever is required, but do we know if they got measles, especially if they come with children and they tend to live in precarious living conditions in the host country? So what kind of, is there a catch-up schedule? Is it by country? What do you offer them? Do you start over for children? In many cases, they don't have vaccine records. So how do you decide what to give them?
Okay, that's a huge question, but I love it because you're asking me, and I'm in travel medicine, and really it shows that public health and travel medicine, they overlap because it's all the same problems. Is how do you know who's been vaccinated against what? Where do you start? What do you prioritize? And you have to look at that. And sadly, in Europe, where they can document their migrant problem and people get accommodated into specific centers, it's possible to define those things, and you can start doing research on it. We've got a huge migrant community in Johannesburg, for example. There's a block of flats that only parle français. Okay, but nobody's got a clue. Those people are scared to go to public hospitals. I'm sure it's the same in Cape Town. And they don't go to public hospitals, so we don't capture them. We don't catch up with them in terms of who's not been vaccinated. It's a problem. It's a challenge for all of you. There's a question that side.
Had a question?
Thank you so much for the nice presentation. I just wanted to know more about the GeoSentinel data you presented. Is it like stationed at the travel medicine clinics? Is the data coming from there, or how is it going to happen? The next thing I want to ask is, how do you ask, I'm sure the data to determine the risk profile of the countries has got to be difficult. So how do you go around that? Because even in one country, for example, if we take a look at my country, if someone is traveling to
From
Ethiopia.
Ethiopia.
If they're traveling to Addis, there's no malaria there. But if they go outside of the main city, there's malaria there. So how do you determine the different risks even within a country, and where do you get the data? How do you travel consult?
Sure. Okay, lots of questions. So on GeoSentinel, I breezed over that because I had the good lady at the back grounding at me for time. So GeoSentinel is a cooperative between the International Society of Travel Medicine, the ISTM.org, if you want to go and look on the website. It's a cooperative between them and the CDC in America up to now. And so there are GeoSentinel centers all over the world. And if you go and look at their website, you'll see on the map, there's hundreds of them in Europe and in North America. In Africa, we've only got 3. Cape Town, it's attached to the University of Cape Town. My clinic in Johannesburg, and we work with the NICD, and then there's one in Nairobi. So we're trying to get the data to feed back to the CDC, well, to GeoSentinel, who in turn will then spread that information. So it's like an early warning system. Hey, we heard there's an outbreak of trypanosomiasis cases, because you don't hear from Zambia or from Tanzania that they've had a CHIPS case. It disappears in public health. But it's important for me. In all the cases we've seen with trypanosomiasis, all the patients were treated for malaria for up to 2 weeks, and then something pops out. So it doesn't get diagnosed locally. And that's why we don't know about it. So it's poor reporting again. So the data for this comes from various sources. The people that put the databases together would be like the CDC, the European CDC, individual countries. We'd go to the NICD and say, you know, what's happening with malaria in the Lowveld right now? We've got an outbreak of typhoid. I'm so proud of my brother. He's an ecologist, but he sent me a WhatsApp this morning and said, look at the rubbish that's going around on the WhatsApp groups in Pretoria. So to our shame, we've got typhoid in Pretoria. Cease, okay? Poor public health infrastructure, okay? And the people are saying, you mustn't drink the water because you will get typhus. And although he's an ecologist, he said, but that was wrong. Typhus isn't typhoid. It is absolutely right. because he knows if he works in the veld, he's concerned about insect bites, etc., etc. But that's not how you get typhoid. So it's misinformation that's going on out there. So we need the public health information from individual countries. And then in places like Europe, where they've got big public health systems, where the travel clinics are typically based in the infectious disease departments of university teaching hospitals, they see those people coming in and they gather the data. So if they see that they're having this month, it was holiday month, typical, all the Europeans go on holiday in August, and they've seen 10 cases of dengue coming back from Thailand. They say, hey, there's something going on in Thailand. And that eventually finds its way into these risk databases and risk maps. But a lot of it is the art of medicine. And that's what I was trying to say a little bit with the meningococcal disease. So who's the real priority? The under 1-year-olds? Now it's a different group. And then we've got a little blip in the student population, the young people. And then we've got a tail again with the older people. Now, when I look at a traveler, so he goes on Hajj, it's easy because he must have a meningococcal vaccine. But now, if he's going to the Sahel, where we've had such a success with the introduced vaccines, should he still get the vaccine? That's what I asked yesterday. The people in the south of Nigeria are not getting the vaccine, but I'm vaccinating my traveler. The answer was, well, if he's got money, give him the vaccine. But not sure that's the right answer. So it's sometimes difficult to make that assessment. When I started travel medicine, I never gave rabies vaccine because we were taught in Glasgow, it's a risk assessment. What's the chances of somebody getting bitten by something that's potentially rabid? And at that time, you had to give 3 pre-exposure vaccines, day 0, day 7, and day 21. And our travelers always come on the way to the airport. You know, it's like, ooh, I need a yellow fever vaccine. So it would have been a waste of money to give them a 700 Rand vaccine, and it doesn't protect them. Then the WHO changed the regime 2 years ago because there's wonderful studies done in Belgium in the army, on the Chinese in the Belgian army, but we don't talk about ethics. And they've shown that just 2 pre-exposure vaccines, day 0 and day 7, obviates the need for rabies immune globulin in a category 3 bite. So now it makes sense if you've given somebody 2 vaccines, and I've gathered cases, including an Ethiopian. I had an Ethiopian in Benin, okay, that was bitten by a bat that flew into his room and struck the ceiling fan, and he picked it up. He thought it was dead, and it bit him. Now, a bat is always a category 3 bite. I had to fly him from Benin via Addis into South Africa, sweet talk him through customs and immigration so that we could give him post-exposure vaccination and immune globulin. Because there was no immune globulin available in Benin, they eventually found some Verorab in Togo that they drove across with a taxi. So cold chain, okay? So I've become more and more inclined, if somebody's going to work in a rural area, if I had children and I lived in Joburg, I would vaccinate them pre-exposure because we don't have rabies immune globulin available on an easy available basis anymore. We don't make our own anymore. It comes from India. I don't really want equine rabies immune globulin from India. So now if I've given the guy 2 pre-exposures, all he needs, if he gets exposed, is 2 post-exposures. If he hasn't been vaccinated before, then he needs 4 post-exposures and rabies immune globulin. And we know of a British guy that died 2 years ago from a dog that bit him in Lusaka, so not wild out in the deep. He did get post-exposure rabies vaccine, and he did get rabies immune globulin, but we don't know about the cold chain. We don't know how it was given, and he died on a ventilator in Johannesburg. So that's the risk assessment. So when do you vaccinate and when don't you? The Cape was always lily white clean, no dog rabies here, so don't worry about it. Now they've got rabies in the seals, okay? And now there's a major problem, and there was a bite 2 days ago. A swimmer was bitten by a seal. It's rabies. So he's got to get his post-exposure. Good.
One more. Thanks for a great talk. I've got a question for you, but I must just share this before. So I tried to download the yellow book, and there's a flag that comes up. It says the Trump administration is working to reopen the government.
Really?
Serious? Yeah.
Yeah, I'm not surprised.
Yeah. But anyway, here's my question. So is there any place for rapid diagnostics? I was just thinking as you were talking about malaria, I mean, you can get a rapid finger prick test for falciparum now. Do you advise your travelers to take some of those with them, point of care rapid diagnostics, or is it just by
Which side are you on? So the Europeans, so in America, you can't even buy a rapid test. It's only available in laboratories. Okay, that's America. In Europe, my colleagues there are very vocal about the fact that if you go into a malaria risk area, you should provide the traveler with, if they're not taking prophylaxis, and even if they do, you should provide them with standby emergency treatment. So there's a box of Coartem in their suitcase, and if they wake up in the morning and they've got a headache and they think this is not just a hangover, this is malaria, then they pop the pills. I think that's terrible, bad medicine, okay? The other advice is go and see a doctor. Sad to say, you know, you can get an adrenaline drip for your chikungunya in the Congo. So a good rapid test on which the traveler has been trained is miles better than just popping Coartem. The problem with popping Coartem is a lot of expats believe it's better to take the treatment than to take the prophylaxis because you've got to take the pills every day. But you know what? I had fever and a headache in Mozambique 2 months ago, and I took 3 of those tablets, and the next day I was fine. So it cured my malaria. So why should I take prophylaxis? Because it's easy to cure malaria. And they don't understand that they just had a virus or a hangover, okay? So a good rapid test. So I recently, in April, I medevaced a 32-year-old German engineer from a drill site in the south of the Congo called Kolwezi. And long story, his Australian insurance company, when 4 hours after we said he must be medevaced, he's got complicated malaria, they said, no, but they're not bringing him to Joburg, he's going to Nairobi. And it was like, why are you taking him to Nairobi? No, because they're medevacing him from Kinshasa. So you've got to have insurance, but they've got to know what they're talking about. If they're sitting in Brisbane, and they don't know Kolwezi is 2,000 kilometers from Kinshasa, and Kinshasa is 4,000 kilometers from Nairobi, you've got a problem. So when we got him to Joburg, he was in full renal failure. And he ended up going home with a dialysis catheter to Germany, 5 weeks later, still on dialysis. And his colleagues were saying, why isn't he getting better? Why isn't it? Because this is malaria. He sent me a very nice WhatsApp afterwards, and he said 4 things saved his life. I'll skip the first one. The second one was the fact that he had a rapid test in the camp. There was no paramedic, no nothing. They're drilling in the middle of the bush. The fact that there was a rapid test that was positive, because being German and wanting to get the job done, when he felt unwell, he was like, well, he'll just stick it out. But when he saw the positive rapid test, he said, okay, there's a problem. And that encouraged him to put up his hand and said, I need help. They took him to the local hospital where they gave him Voltaren to bring his fever down because he's German, so he's allergic to paracetamol, so they couldn't give him paracetamol. So when the next morning they said, his temperature is still 39, he's vomiting blood, I said, he must come out. But the rapid test was an incentive for him to actually, it didn't make him stay, but it made all of us say, this is malaria, and it's complicated malaria. Of course, a negative test is just as important, because if you've got a temperature of 39.5 and you've got a negative test and you haven't got a rash and a swollen joint and it's just chikungunya, it might be the guy with the S shot on his back from Zuzu in Malawi that they haven't turned around and been treating for 2 weeks for malaria, 24-year-old Brit, and he died in Johannesburg from trypanosomiasis. So a positive test, a negative test. So the guy who goes to America where they don't have the rapid test available outside the laboratory, he's sitting in Tennessee where the local GP in the dorp has never seen malaria. Now, if he can haul out his rapid test, test himself, and then phone me and say, I've got a positive test, but my doctor says it's flu season in America now, it can't be malaria. I'm going to phone the doctor and say, you better get this guy to somewhere where they know about malaria. So rapid tests are good, but it must be a good quality rapid test. Apparently, you can make them in your garage. So there's lots of poor quality ones. 95% of the malaria in Africa is falciparum malaria. So that's the one that kills you. I couldn't care about your Vivax and Ubale. So we only provide the single species rapid test so that you know what it is, because the others, the multi-species, are confusing to read, and they're not that clear on how they work. Thank you very much.
Thank you. That is very good and entertaining, like I said.
All right. Bye.
Our next speaker is joining us online. Associate Professor Sipho Dlamini completed his medical degree and internal medicine training and specialist infectious disease training at UCT and Colleges of Medicine South Africa. His research interests are HIV and TB, and the use of vaccines in people living with HIV infection. And he's going to be speaking to us on life course immunization, expanding protection beyond infancy. So I'm not going to speak anymore. I'm going to let Sipho take over.
Good, thank you. Good morning, everyone, and I hope you can hear me.
We can.
Thank you, thank you. It's really grateful that you have allowed me to speak to you today, and really the next 30 minutes is just going to be me taking you through life course immunization. I hope you can see my slides as well. Yes?
Oh.
Can you see my slides?
Yeah, we can now. Thanks.
Okay, great. Okay, so I think for far too long we've been talking about vaccination in children and thinking that's all that it is. But really today I'm going to suggest to you that we should look at life course vaccination, and this is just vaccinating people throughout their life. And I'll take you through why this is certainly part of the global agenda, and then give some evidence for why there's a push for life course vaccination, and then give you a suggested life course vaccination, let's say for Africa or South Africa, or suggested vaccines for adults in our context. So these are just some of my disclosures. So I think to begin with, historically, vaccines have been part of what we do for quite a long time. And I think you will appreciate the benefits of vaccination in terms of the number of deaths that have been averted. And certainly, if you look in the past 50 years, relating to the 14 sort of vaccines we've been used in our childhood programs, you can see that we've averted at least up to 154 million deaths. That success has probably also translated into people living longer. However, I think we probably have reached the limits of how long we can live. And the question is, how can we encourage healthier living or healthy aging? And certainly, I'm suggesting, and there's a suggestion that vaccines are key in fostering healthy aging. So benefits not only in children, but also in adults in terms of a key health prevention activity. I share with you this article that was, I think, released sometime in the middle of this year, just again highlighting the success of the vaccine or immunization program, EPI program in China. There you can see the impact, both the health impact and economic impact of vaccination. So the EPI in China averting the number of deaths, but also probably averting the number of infections. And that analysis, I think, just looked at 8 key vaccines that were used in that program. And you can see that the costs or economic impact of vaccination or the EPI program in China in terms of the benefits to that society really going into the trillions. Certainly, beyond just deaths and infections, its data has again coming out just how vaccines have been key in many contexts across the globe in certainly mitigating against highly resistant infections, also reducing in hospitalizations for vaccine preventable illnesses, and certainly this data includes data from low and middle income countries. In fact, most of the data suggests that in low and middle income countries, vaccine have been the most beneficial. So the idea, therefore, is that life course vaccination is not just about vaccinating children, but it's about vaccinating beyond childhood. And it's also not about just particular stages of life, but it's throughout one's course. So, maternal vaccination isn't life course vaccination. It's probably part of it, but it has to be seen. So life course has to be seen as vaccination throughout one's life, and not just maternal vaccination or adolescent vaccination or vaccination of the elderly. And how does life course vaccination fit in the global agenda? It fits in the global agenda because it's been recognized by many of these global agenda documents that we've produced. And I think Tony highlighted the WHO Immunization Agenda 2030. But there are many of these declarations that we've made, and also at the World Health Assembly, as a strategy of looking at a life course as an approach to fostering healthy aging and functionability. And it's thought that life course approach to vaccination is going to help us meet some of the SDGs that we've made declarations on. So certainly life course vaccination fits in with the global framework of how we are approaching health as a way in which to foster healthy aging and keeping people functional. Now, of course, the question is going to be, how do we do it? There are a number of documents that have looked at this and been produced in giving some sort of conceptual framework of how to approach life course vaccination. And the key real issue here is that it's part of this idea that we keep people functioning throughout their life so that they can meet their intrinsic functional abilities and keep their capacities and therefore live better and age better. It's thought that this idea would then allow us to deliver on universal health coverage, also fostering better social and human rights for all global populations, and really is something that we're calling on all sectors of society, not only government, private, and civil society, to really put our energies towards it. Of course, in this particular document I'm sharing with you, tries to outline this conceptual framework, but also highlight some of the key challenges that are there. And I think many of you might have discussed it throughout this week, but really some of those are policy-related issues. Some of those are political-related issues about our political frameworks tend to be short or change often, and therefore don't allow us to begin to build on life course vaccination, especially in our part of the world. I put the slide just to show to you where we are in terms of Africa. The life expectancies Africa is growing. Certainly in Southern Africa, when you look at males and females, the life expectancy, if you're male, is closer to 60 and 65 if you are female. But you can see across the regions that our people are living longer and projected to live longer. So if you're born in 2023, the expectation that your life expectancy would be 60 years and above. And if you just look at our age distribution in Africa, we've certainly got a younger population, but the older population is certainly set to grow. Of course, there are going to be consequences of living longer, and I've listed some of those. You'll see that infections doesn't necessarily feature, but some of these metabolic conditions, and I've highlighted them in blue, cardiovascular disease, can be made worse by infections, and probably is something to think about. But I think the silent epidemic that we're facing in the continent is going to be obesity. If you look at the projected obesity rates for South Africa and Africa, you can see that that's growing. Already up to a third of our population is said to be obese in South Africa. The projections are that 2 out of 3 people living in Africa by 2030 would be obese. And that, I think, presents with it some health implications, but one of the ones relevant to us today is this infectious risk. So these people are going to be at risk of some of the vaccine preventable infections. And you see there some people have, things like COVID, but there are other respiratory infections which they would be at risk of. And if you look here, if you just look at the top causes of death in 2024 globally, you can see that lower respiratory tract infections feature as number 4. And the people dying from these conditions, such as pneumonia and influenza, are people with who have either some immunity or the elderly, which poses them at risk of these infections. And many of these lower respiratory tract infections are vaccine preventable. So certainly some reasons why you would look at vaccinating adults, for example, for vaccine preventable infections, because that would certainly prevent some of those infections and therefore prevent death in some of those groups of vulnerable adults. Now, just as I've put up or mentioned the issue of vaccinating throughout life, but more particularly adults, it's not that there aren't any guidelines for vaccinating adults. They are, but there has been some challenges in meeting some of those targets. Like many countries would have a guideline or suggestion that adults, especially with immunocompromising conditions or some of these metabolic diseases, that every year should get the vaccinations. And often that doesn't happen. And there are many reasons for that. They may be doing with, some of the education of healthcare workers, education of the public, but the availability of vaccines in facilities or not. And also sometimes this idea that perhaps it's not cost effective to vaccinate adults. But we can see that the evidence suggests that when you look at vaccinating adults, certainly there is an economic argument to be made for it. There is also argument to show that the burden of disease is high in adult populations and that using vaccination as a strategy is key to preventing those. There's also data to show the costs, and which I'll show you in some slides going forward, just about the cost of some of these vaccine preventable diseases on our health systems. So this is real data from the US, just looking at 4 key vaccines which are preventable and which directly affect adults. And you can see some of the direct and indirect costs. And these are 10, 20, and 30-year projections. And you can see that certainly if the US, for example, doesn't intervene with a vaccine strategy for these 4 vaccines, there are projected costs or cumulative costs to that health system as to what will happen to that society and what the cost will be to that society if they don't introduce a vaccine strategy. So certainly the data is there to show the impact of these diseases, and certainly not only directly to the individual, but also to society and also then to our health systems. So certainly, again, suggesting that one can't ignore these infections in this population group. And subsequent to that, and this is data just showing that when you just not only look at these 4 vaccines, for example, you can also count some of the other aspects of benefit to society, which we haven't generated data for, but are beginning to emerge. So vaccines in adults are not only just to prevent that infection, not only just to prevent, say, hospitalizations, but there are other value-added benefits, such as the impact on AMR, for example, the impact on productivity, on society. All of these are other things that may be of value to policymakers when looking at adult vaccination. So certainly important. And this is quite important because if you look at also the projected numbers of people who are going to be over the age of 50 in 2050, the projections are that a third of the global population is going to be above the age of 60. And I think the projections are over close to 2 billion people will be above the age of 50. And many of those, above the age of 60. And many of those who are above the age of 60 are at high risk of these infections. So they're at high risk of influenza, pneumococcal infection, RSV, and herpes zoster, either because of some of the impact of the metabolic conditions that I've highlighted before, or just because with aging, they have got decreased immunity and therefore would become vulnerable. So certainly if you are thinking about making sure that you keep people functional and healthy, you have to then think about introducing some of these vaccines into either the adult population, either because they've got a comorbidity that requires it, or the age is an indication for them to be vaccinated. And just highlighting that, you can see from the slide, is just that the American Society of Cardiology and the European Society of Cardiology have identified certainly influenza, RSV, COVID-19, and zoster vaccination as key vaccines for their populations who are suffering from heart disease. One is because they recognize that if you prevent these infections, you reduce the number of myocardial events. But also certainly when it comes to zoster vaccine, for example, there is emerging evidence that being vaccinated with zoster, as is indicated in many countries above the age of 50, in some countries, or above the age of 60, that there is benefit of it significantly lowering your risk of heart attack and stroke. So this, again, emerging evidence is why some societies are recommending these vaccines, because of these other benefits other than just preventing that infection or hospitalization really related to that infection. These other unintended consequences, which are good from the vaccination, so preventing stroke or heart attack as an example. Just also other emerging evidence is that vaccination in the elderly, we're beginning to see also when you look at influenza in terms of that benefit, in terms of its consequences, certainly in adults, in that, again, when you look at some of these analyses, able to reduce antimicrobial use, which is become important in the area of highly drug-resistant bacterial infections. So if we can reduce the number of antimicrobials that we prescribe, we're going to probably have an impact on this issue of highly resistant bacteria. Certainly, other evidence has shown and been shown, especially with the rotavirus for children, how it's had an impact on AMR. And certainly, other evidence and reviews are showing that even RSV directly or indirectly has an impact on AMR. So this is just to share with you some of these other impacts of vaccination, which aren't really directed to sort of the disease prevention, but certainly AMR. And I highlight it here because often when the vaccines are trialed or research done, we don't ask the manufacturers to also show to us their impact on AMR, for example. And perhaps going forward is one of the things we'd request when new vaccines are introduced, to see that impact. We often ask for cost-effective data, etc. But certainly looking at how vaccines are a key strategy for AMR is also important. So this is, I think, 2018 data, just looking at which countries had an adult vaccination program and regions. And really, just to say, by 2018, there were not many African countries who had a adult vaccination program per se. And this was just looking at some of these vaccines, so the hepatitis B, HSV, PCV, and influenza vaccine. So that has changed a bit since then. And certainly in South Africa, we do have an influenza and pneumococcal vaccine guidance, but that's really targeting people who are above 65 and have high risk conditions. We certainly don't have a national program for herpes zoster vaccine, and others for adults. But certainly there's work now beginning to look at life course immunization. We certainly are embarking on maternal immunization in this country, certainly looking at RSV, for example, as one, with already tetanus, diphtheria, and tetanus and diphtheria and pertussis as vaccines that are given in pregnancy. And I think that will expand as well to include other adults who are at high risk. For example, in the province you're in, the Western Cape, we've been having an outbreak of diphtheria in young adults. It's probably because they missed their booster dosing in their teenage years. So certainly, as we begin to see evidence of just some of these vaccines emerging when people are not boosting, speaks to the fact that we do need a life course vaccination program to really address and stop our populations from being vulnerable to these vaccine preventable illnesses, and certainly highlighting that it looks like the vaccines, even if you've gotten your diphtheria vaccination as a child, you will need it in your teenage years, and certainly need it probably later as an adult, so that we don't have the outbreaks that we're currently experiencing, for example, with diphtheria in the Western Cape. So an example here is just Bangladesh, what they've done to think about really looking at life course. And this is just what they've decided to do in terms of how they'll embark on life course vaccination in an attempt, of course, to meet their SDGs. And you can see here, they've obviously have a EPI program, but beyond that, you can see that they seem to be targeting women of childbearing age, and have introduced measles, rubella, tetanus, toxoid, for example, as what they would consider as a start to their life course vaccination approach. So some countries are beginning to take this seriously and are looking at ways in which they would build on their vaccination program just beyond EPI. In India, for example, they have taken a different perspective. They have highlighted some of the key vaccines which they want to add to their life course vaccination approach. And what they've given there is who they will give it to, where the activity will take place, and also by whom. So you can see that they've taken a different approach, and certainly are then going to try and build that on to their vaccination program. So I suspect you want to ask me, what does life course look like? And certainly what we are trying to build is life course as depicted in this slide, where you can see that while you're pregnant, or 1,000 days before birth, or the first 1,000 days during pregnancy, there are key vaccines that you'll get. During your childhood, you'll get those particular vaccines. And then as an adolescent, there are key vaccines you will need. As an adult, there are going to be another set of vaccines that you will need. And then as you age and reach the realm of being called an elderly, there are going to be vaccines that you need. Now, this is just not prescriptive, but it's just to give you a sense of some of the vaccines that may be indicated in particular stages of one's life. Now, of course, to implement life course vaccination requires certainly a policy framework, investment into it, and ensuring that your health services and systems are geared towards delivering that. Of course, this is part of trying to ensure that you get universal coverage, addressing people's needs, and really ensuring that you reach all the people that need it. I think this morning you're having a discussion about zero-dose children, and that is indicative probably of something to do with our health systems and services. The other thing, of course, is that you have to get all the stakeholders involved and then be able to measure what success looks like, monitor, and certainly make sure that there is research in terms of understanding the disease burden and epidemiology of the context in which you are in. Certainly, I think having said the above, really, it's all about making sure that our health systems are strong. And I think it is important that you can't do this without really looking at investment at doing that. And then also what is going to be important is how you measure things, and some of these outcomes then become important. I've put equity there because we often are challenged in our systems about ensuring that we have equity. And then, of course, is also the challenges of how we deliver vaccines in a context where there may be vaccine hesitancy. So how do you educate both the vaccinators and the recipients and the communities, and essentially understanding the knowledge systems where you work, and therefore address those so that we have a successful vaccination program. So if you ask me, what would life course vaccination for Africa look like? This is just something I think would be important. Certainly heavily biased towards some of these respiratory related vaccine preventable infections, certainly in the adults and elderly, but I think because the data speaks to that. And then obviously there are going to be certain vaccines in the adolescent which need boostering, which are there. And then I think many countries have a HPV program, but I think the challenge is making sure that although the programs are active, how do you ensure that coverage and recover all the girls that need to be vaccinated adequately? So what's the way forward? Really, I think countries need to start thinking about life course vaccinations, get the policy framework in place, make sure it is financially supported. There's going to be need of advocacy to drive this, and we probably do have to think of what are the low-hanging fruits. So key populations may be the way to start. And then, of course, think about priorities. And I think for South Africa, certainly, when you look at respiratory infections, big cause of death in many of the key populations, and really to advocate for those vaccines to be made available so that we can begin to build and strengthen a life course vaccination program in the country. And then there's going to be a need to really go hard on communication on the benefits of vaccination and its importance, and of course to highlight to many of the stakeholders what those benefits are to not only themselves but also to society. Just one or two slides before I end. Of course, the issue is going to be what comes beyond that. Certainly, I've highlighted that there are going to be new vaccines that are going to come up that are needed. Some are going to be targeted at how we challenge the antimicrobial resistance that we're faced with. So there are going to be some new vaccines or vaccines that are being developed to target some of these key infections. I think the TB vaccine in adults is a story that is beginning to emerge, and discussions about how that would be implemented and where you'd want to place that vaccines. Certainly, it sounds like it's going to be a vaccine probably best placed for adolescents. And then obviously there are going to be discussions of how that is rolled out within sort of a framework of either life course or existing programs in countries. So just to conclude, I hope I've saved some time, but really a snapshot of what life course vaccination should be. And I think it's time that we really expand on vaccination just beyond childhood, really put the policy frameworks that are necessary for it, put the financial resources that are necessary for it, and then really to strengthen our healthcare systems, because I think already these declarations have said that that's the way in which we're going, and we need to begin to work towards that. And really, vaccines, I think, in adults have demonstrated their benefit not only to the individual but to society as a whole as well. So certainly a key intervention in health, a key intervention to certainly address health inequities, especially in our setting where we are challenged with costs and the burden of some of these infections in our populations. So I think with that, I'll stop there and happy to take questions.
I'm going to first ask the people in the room if there are any questions for Prof. Any? Okay, actually there's online. Okay, I'll take first the one in the room and then I'll pass the mic to you.
Yeah, thank you very much, Prof. My name is Jason Mwenda. I think you've made a very strong case for the life course approach to vaccination. I think you managed to convert most of us in the room. But I'm just wondering, in terms of the health systems, I think you mentioned some of the three elements where we need to make some adjustments. But just thinking that in Africa, the health system still is not sort of ready for the life course approach to immunization. Just wondering, what else do we need to do to make sure that the health system actually is sort of ready for this? Because there are more vaccines coming where we need to make sure that even the adults are being vaccinated. I'm also thinking about the data systems, for example, the vaccination card. How should that look like if we are really to effectively implement the life course approach to vaccination? Thank you.
No, thank you very much for that question. I think really it is a challenge for our context in Africa about how do we begin on the journey of life course vaccination. So I think part of it is to think about the policy framework. So how we are rendering vaccines, even in the EPA programs in many countries, it's siloed, right? And I think one of the things is try to move away from these siloed vaccine activities. Which is going to be a challenge. But I think in my thinking, one, we have to begin to think about, each country needs to think about its systems and think about which cadre of healthcare worker is going to do that activity and where that activity is going to take place. Is it going to take place in primary care, or is it going to take place in a different place? For example, how do we leverage for example, the HIV programs to begin part of that life course? For example, in some countries, especially in Southern Africa, HIV populations are a large population, a key population. It's quite easy to introduce a vaccine program into that because there's already an activity geared for that population. But then what happens to those who are diabetic and have heart disease? How do you reach those populations? So a challenge there. I mean, maternal vaccination is probably easy because there's antenatal activities. So introducing vaccination in there is quite easy. But again, what I was highlighting is that maternal vaccination is not life course vaccination. It is an activity within it. And I think we do on the continent need to think quite clearly how we're going to do that and what needs to change in our systems, and whether primary care is where it takes place. I think it makes sense that it takes place at primary care in many countries. The data systems that you speak about, yes, true. For example, the vaccination card, I think countries need to think that your vaccination card from birth until you die should be one card. Then we can think about how do we use technologies to leverage on that. For example, in this country, in South Africa, where you are, for COVID-19, every adult who got a COVID-19 had it digitally recorded. We've lost that platform. I thought it would been a very good platform to begin adult vaccination because you start with COVID-19, and then if you get your pneumococcal vaccination, it's digital, it's accessible. The beauty of that system was that if you traveled, you could prove at the border that I had my COVID-19 vaccination, and here's the digital stamp for it, which is also what we need on the continent, especially given the mobility of our populations and some of how, if your country is at peace today, but tomorrow you wake up, there's a civil war. If it's digitally recorded, you don't have to run with your vaccine card, which may get lost along the way, but at least there's some digital record of it. So those was just some of my thoughts. I think probably most of you in the room have brilliant ideas of how we should move in the continent.
Thank you, Sipho. We have a question online from Alan. So he just says thank you for the informative session. And his question is on maternal vaccination. Do we have a GBS vaccine? Because this is Group B Streptococcus vaccine. And are there countries that are currently implementing it?
The answer is, I think the GBS vaccine is, I know there's lots of movement on it, and certainly the data is looking good. I'm not aware of any country that has really started on a GBS vaccination program. I'm not sure if there's others in the room who have any later knowledge of where we are with the GBS.
Thank you so much, Sifu. So here is Iman. So the next session, we will have a talk on maternal immunization with Claire Catland. So please keep all your questions on maternal vaccination to Claire. And now just ask Prof. Sifu on life course, except maternal immunization.
Is there anybody else in the room who wants to ask a question? One final question, preferably from that side of the room. Prof, it looks like you're off the hook.
Thank
you
you.
very, very, very much for an excellent presentation and question and answer session. And we are going to go to tea now.
Thank you very much and enjoy your tea.
Okay, everybody, please be back sharp at, is it 11? 11.
Hello, everyone. Hello. Good morning. Bonjour. Sabah al khair. Please. So, I know that you're busy with your presentations, but this is my favorite session of the week. So I guarantee you that you will enjoy it. So I need your attention. And for those who ask me about where they need to send their presentation or their work for the think tank session, Lisa actually shared a link on the WhatsApp AAVC 2025 AAVC delegates. There is a link to a Google Drive. So you upload your presentations or your posters there. So you're not going to send it to anyone. You just upload it there. Okay. So now we're starting as you know, my favorite session on that has maternal immunization, HPV, etc. So the first session will be with a very lovely lady that I had breakfast with her today. I just known her today. It was nice to meet someone that you're gonna present before the session. So our next presenter is Fumani. She's a public health professional and immunization health system strengthening expert with extensive experience in leadership and management in the health sector. Currently, she works as the head of evidence partnership leading global efforts to strengthen HPV vaccine equity through strategic evidence partnership. In addition to that, she's a very inspiring woman, African woman, and please pay attention to Fumani. Where's Fumani? Here we go.
Thank you very much and good morning, everyone. What an inspiring bio. Even I was so surprised to hear it. Yes, so as she has already said, my name is Fumani Lekwala and I hail from the Future Evidence Foundation as the head of the HPV Evidence Partnership. So I've been tasked today to talk to you about advancing equity for adolescent girls. We've been talking this week and had inspiring messages, challenges, achievements on the vaccine landscape in Africa and globally. So it is my pleasure to take us back and concentrate on what we are doing as Future Evidence Foundation for the HPV vaccine delivery. So Alliance for Living Evidence Alive, we are an organization that envisions a more just and equitable future. And Alive's role in achieving this vision is in building systems that empower decision makers to make evidence-based action. And we do this to solve society's most pressing challenges. So we work with decision makers. In our case, the case of HPV, decision makers are country EPM managers, country NITEX. And I learned at this gathering that actually EPM managers are non-core members of the NITEX. And it is my pleasure that I will be inviting everyone here who is a part of NITEC to join us as we continue. So moving on, we know that cervical cancer is a public health crisis in Africa, specifically in sub-Saharan Africa. We know that also that this tragic reality is particularly poignant given the fact that this disease is largely preventable through human papillomavirus. And it is very saddening that annually cervical cancer cases, we see 100,000 new cases of cervical cancer, and roughly 2 out of 3 of those women who are diagnosed with cervical cancer end up dying. And this is a very preventable disease. We also know that, sorry, WHO in 2017 launched a strategy to eliminate, towards the path to eliminate cervical cancer, and HPV vaccines are key as primary strategy towards that. And the goal is to vaccinate 90% of girls by the age of 15 by 2030. At the end of 2024, 32 out of 47 countries had introduced the HPV vaccine. This comes from the WHO website. And at the end of 2024, 47% of girls have received at least one dose in the region. We have heard about how countries are now pushing towards giving only one dose for the HPV vaccine in the countries. And we know that Gavi is working very hard towards making sure that we reach the target of vaccinating 90% of girls by 2030. And we have Gavi in the room, so some of the questions, if they're related to that, I'm very happy that we have them. So when it comes to decision making, sorry. Am I able to? Okay, no problem. So when it comes to decision making towards introducing HPV vaccination, we know that we'll be looking at policy and national guidelines. A country will need to decide whether it will first need to decide that we are going to introduce a vaccine. So there's a lot that goes into that. The decision includes whether the vaccine will be, delivered through schools, what type of the vaccine it will be, and that also will include planning and preparation, communication and social mobilization, training, implementation, data monitoring and evaluation. All sorts of those are the decisions that the people we work with in our countries have to make. So the key barriers that we have seen, and this is not an exhaustive list, we know that delayed vaccine introductions play a very big role with regard to the inequities that we continue to see in our vaccine programs. We know that within our nations, even if our coverage may seem high at the national level, we know that subnational equities persist. We also know that because of the school-based vaccination delivery, most of our out-of-school girls end up not being vaccinated. We also have been talking over the week about stigma and misinformation, parental consent hurdles, and all others. So I just wanted here to pause and talk about my own experience of being part of the team that helped reintroduce HPV in Lesotho in 2022. So Lesotho introduced HPV as part of a demonstration project in 2009. It was introduced in 2 districts. And then in 2012, Lesotho scaled up the vaccine nationally. And that went on for 3 years. By 2015, the vaccines, so actually this was a donation from Gardasil, the manufacturer. By 2015, the vaccines had run out. And the country found out that the vaccine was actually too expensive for us to continue with it. So we halted vaccination. That is when in 2016, Lesotho went to Gavi and asked to be eligible as one of the Gavi supported countries. The approval was received in 2017, and then we started the journey towards applying for an introduction grant. We applied in 2019, And in 2019, early 2020, our application was approved, and then we started the journey towards introducing. But then COVID hit. We're supposed to introduce in 2021, but COVID hit, and we had to focus on responding to the COVID pandemic, including introduction of another vaccine, which is the COVID-19 vaccines. And we have had how that's through the life course approach that we keep seeing. We heard about pandemic response, 100 days towards a new vaccine in the event of a pandemic and all of that. So that was that. And then eventually in 2022, we introduced the HPV vaccine. But that was not a linear journey. We had so many decisions to make as a country, and we needed so much data. When you do not have a repository of data in the country, we also talked about that, the lack of credible data in our countries. You scramble to get the data from everyone who worked on the previous introduction. You get some you do not get. That's fine. But also, you need to also know what other countries are doing. In our case, we knew some people in Zimbabwe, we knew some people in Tanzania. So we could talk to them and say, hey, can you share some of the information that you have, the guidelines, whatever that you have, that you can share best practices with regard to your introductions? But that takes time because we know that EPI managers are busy. People are not waiting for you to ask for the information. The information will come, might come, and it did come, and it helped us a lot. But it could have been timelier. It could have been easier to get. And some of the information that we already had could have been easier to use and to adapt to our context. With that, I want to bring us to this pool that we say we've been looking at all the vaccines that have been introduced, that are in the pipeline, that we're going to keep to introduce. So it's a whole pool of evidence that we have available to us. But is it usable? Are we able to get it in the instant that we need to use it? And that is the solution that the HPV Evidence Partnership is trying to bring to our doorstep. So the mission of the HPV Evidence Partnership is to strengthen the HPV vaccine evidence ecosystem to enable high, sustainable, and equitable coverage, with the goal of ensuring that our decision makers, and these are the teams and the people that run HPV vaccine programs in our countries, have the evidence that they need when they need it. And in this initiative, we are working with country HPV vaccine delivery decision makers and advisors that I've already mentioned. So we have this model that we believe is a system. This is how a living evidence system looks like. By living, we mean that if we have evidence, we've already looked at that pool that is vast and inclusive of all the evidence that we have in the vaccination space. The living evidence system is having that evidence accessible and usable at the minute, and that an EPI manager would like to make a decision on something. They should just go into that pool and be able to bring something that will help them make a decision in a timely way. So we're looking at a living evidence community, because what is a system without the people that drive it? So a living evidence community of HPV vaccine delivery decision makers and advisors. We have already talked about them. There are NITECs. They are our EPI managers. They are the people that we also collaborate with. We've heard about the experience of Kenya yesterday. We need, in the case of HPV, we need the Ministry of Education local governments, we need social welfare. And then this community also needs to be facilitated to make sure that we prioritize the needs and engage with the evidence and use it to inform decisions. So decision makers who are the country partners, they prioritize and drive what information is included within the database. And then within that, that leads to a living evidence bank. By living, we've already said that it is continually updated. So it is relevant, it is up to date, and it is very accessible and open source. So this includes comprehensive, rigorous, and living evidence of HPV vaccine delivery. And again comes facilitation. So this is a facilitated generation of comprehensive, reliable living evidence. And this living evidence helps decision makers and serves them to help them make timely, relevant decisions when they need to. So that's how we see a living evidence system. So back to HPV. We know that all the HPV programs, the goal is to reach high, sustainable, and equitable vaccine coverage. We have talked about all the decisions that go into informing programs to achieve this high, sustainable, and equitable vaccine coverage. And we have talked about the evidence on HPV delivery that is available out there, vast. But we have seen, as we discuss with people within the HPV vaccine coverage ecosystem, that this evidence is sometimes it's not usable, even though it's available. It's difficult to implement. It's in different places, meaning that it's haphazard. It's not together. So what the solution that we are bringing as the HPV evidence pandemic is a living repository, which is a data bank that includes all HPV delivery evidence available out there. And then this living repository will also be able to be viewed as a map that is interactive, that a decision maker can just click on a button and get whatever they need at that moment to make an informed decision. And then we are also working with the EPI programs in the countries that will come to that in the next slides to develop living systematic reviews. We have been commissioned to deliver up to eight living systematic reviews. And then we'll also work with these decision makers to deliver a living evidence use tools. So this will be mainly guided by the decision makers. How do you want to receive your data? How do you like to interact with evidence? With my experience in Lesotho, I found that I can read studies, but it was really difficult for me as an EPI manager. We're all EPI managers when we work the programs, to translate a systematic review into the decisions that I would need to make. So this is why we are engaging with country decision makers to say, how do you want to see your data? So within this evidence community that we're building, we have a steering group, which is made of country decision makers, as we have already said. And then we have the advisory group. And this includes global stakeholders. We have Gavi, WHO, UNICEF, VACFA is also part of the steering group members. And then currently we are building what we call a tactical team. This is a team that will work closely with the teams that will be working on delivering on the living systematic reviews. So the steering group has been established, and as was my call at the beginning of this chat, to invite all the NITAGs, all the country decision makers in this room to be part of the HPV evidence group. We need more voices. We need more people with experience of delivering on these programs to support and shape how they look like. So the rationale for the steering group, we are going for a regional balance across Africa and South Asia with varied program maturity. So we know that some countries are introducing, such as India. We know that some countries are reintroducing, such as my experience with Lesotho, and then some countries are scaling up. So we need that mixture of experience to lead this partnership. And then we are also looking at the complexity. We've been talking about how challenging it is to integrate a new vaccine into the already existing system. We just saw a presentation on life course, vaccination across the life course. That also brings another complexity to the already complex and dynamic EPI program. We also would like evidence-driven leadership and governance readiness. So the partnership, the steering group sits monthly virtual meetings. I've already extended an invitation, but we are actively working to consult with RITEC and NITEX to understand how the partnership can better help or add benefit to the work that they already do with the countries. And yes, we are here with the VACFA. So currently we have Ethiopia, Lesotho, Liberia, Rwanda, Kenya, India, and Uganda engaged. And some of the questions and decisions that the countries are already asking include how do we integrate HPV vaccine into especially with the current landscape of funding into our health facility-based vaccinations, because school-based vaccination is becoming very expensive. And also questions of immunogenicity with regard to shifting to one dose. Countries are asking some of those questions. India is soon to be introducing, and they're saying, what are the best practices that we can glean from what has already been done in other countries? So we are expanding, and we're looking forward to welcoming more of you into the partnership. And then for the living evidence system, I've already mentioned that we have built a repository. It is up and running, and we'll be publishing it this month. And I will share once it's done, but I can also share a link to the repository after this meeting. I can share it to the WhatsApp group so that you can interact with it. We're looking for feedback into how easy it is to use, if you see value in it, if it speaks to your needs as a decision maker. Because it's really meant to support sustainable uptake and help you make the decisions that will sustain HPV programs. So our hypothesis going into this is that we're hoping that this system will be trustworthy, up to date, and relevant. And then another next step that we're doing is we've started identifying living synthesis topics, as I've already mentioned, but we are also hoping to engage synthesis teams as sub-awardees under this initiative from the African context, people who know the African context. So if you have any such knowledge of such teams within the African context, please do reach out, and we can give them the EOIE. So as next steps under this, we're looking to deepen our engagement, as I've already alluded to, and we're hoping that we can use leverage on AI to make sure that however decision makers want to visualize their data or interact with the evidence that is in the database, we can use AI to kind of bring costs down and make sure that we deliver Thank you. So there's an invitation, as I've already said, to look, we're looking for insights on the living evidence system that we are building. We also need your advice on how to make this better. How do we interact with the data in a better way that is useful for our programs? And we are also extending participation into the advisory group, the steering group, and the tactical groups. This is how the repository looks currently. It might look a bit different once it's published, but this is the current version that we have. And with that, I will stop here and wait. If we still have more time, I could go into
We still have
repository and just do a demo, but I think it will be better if everyone just does it.
No,
by
we still
themselves.
have 10 minutes, no, 15 minutes, 14 minutes. So you can, if you want.
Okay. Let me just open it and see. This laptop is very old. Sorry.
Taking photos.
Let's see. Okay. Oh, how do we?
Take the photo with us.
I'm not used to this. Yeah.
This one.
Yes. It's the entire screen.
Oh, it's in the
Yeah. Thank you very much. So this is how the visualized repository looks like currently. We can view it by country or regional focus, by continent, World Bank region, thematic group, study design, a vaccine schedule, and all of, there are so many ways of how to go about it, depending on what you need. My screen is so small. I don't usually use this kind of laptop, so it's a bit difficult for me to try and but we can go into the thematic focus because that's what I know that our programs usually have to do with. And then, do we have a mouse for this? And it doesn't look like there's any way it can go in.
Take this clicker out.
Oh, we
And yeah,
oh,
put
that's
it in
the
the,
picture. Oh,
or you can put it in the seat.
let's see. Yeah, this is the. I don't see it. Uh-huh. That's not right. We don't seem to be winning. So I think I will just share the link into the WhatsApp group and we can come back to me with your thoughts when you have interacted with it.
Thank you so much. A big applause to Humani. So now we have 15 minutes more for questions. We start with in person.
You want to ask? There is a lot of feedback. Okay, thanks very much. Thanks for the presentation. Actually, this is an issue that actually raised concern at one of our NITAG meetings, because you find that since 2015, we've been vaccinating against HPV, but you find that the uptake has consistently been low. For example, the second dose is as low as, I think, is it 15%. And of course, my background is in bioethics, and I do a lot of qualitative work. So, I mean, studies have been done, okay? And they've documented a lot of, misperceptions, lack of knowledge, teenage marriages, etc. But I think the evidence is there, and the Ministry of Health, I'm sure, knows what to do. But the approach, and I believe this might not be only in Uganda, the approach to how they engage the communities. For example, early this year, there was a national immunization drive for HPV. And the Ministry of Health used threatening language, threatening mothers that if you do not do this and that, and basically it was a school program. And actually, do you know what happened? Even the parents threatened to sue government, try. You see, the way we package the information, and actually the community engagement aspect is poorly done. So my question is, we as Africans, how can we approach this in a better way to ensure that actually our girls are protected? The approach to this matters a lot. There is a lot of information, but the translation of this knowledge into policy, into improvement in treatment guidelines is really lacking. And I believe this is not only in Uganda, but in other African countries. Thanks very much.
Very much for those insights. I believe that is a question to the floor as to how we can help improve that, because if evidence is there and we know what to do with it, but we are not doing it, what is hindering our use of this evidence in our countries to translate it to helping us to improve, our vaccines coverage, our HPV coverage?
So before going to the next question, who want to engage with his question? With Erisa's question? You want? Okay.
So I just want to engage with that because I think it's such a brilliant contribution, because it seems to me that this is such a highly effective vaccine. And one of the issues that keeps on coming up again is communication. Yeah. So I'm wanting to ask you, okay, to what extent because you had, I think in the very beginning, you had communication as your fourth block at the top. And it just makes me wonder how much funding goes into that, how much energy goes into that, given that we all know that HPV is controversial. And it's controversial across a number of sectors. So it's not just only parents. And I'm just thinking also about religious leaders, because that seems to me to be a massive stumbling block. And, you know, in some countries where religious leaders have been engaged with, they have actually been pivoted, turned around to actually, once they understand, to actually understand that this is actually not a sexual debut vaccine, for example. And it just amazes me that we know this, and yet this is still not happening. So I would ask all of you actually to cogitate, to think about how much effort is actually put into that. And I mean, I know that it's a difficult thing because, and I know I'm going to ramble on and Greg's going to get cross, but it just seems to me that to a large extent, we don't actually take it on as part of our work. And it's totally understandable because you're so busy doing repositories and the evidence-based information and trying to get to grips with that. But on the side, you know, it's actually not acknowledging where the community's at. Because if they don't really understand, then they become the victims, okay, of misinformation. And it is so vitally important that parents are engaged with and that religious leaders are engaged with. So I couldn't agree more with my colleague over there.
Thank you very much for that brilliant contribution. And I see that our colleague Gavi wants to add to that, or at least respond.
Yeah, thank you so much for Mani, and thank you so much for that contribution. So I just wanted to come in from the angle of community listening. So at Gavi, we work a lot with different partners, but mostly UNICEF, and maybe the UNICEF colleague in the room can also contribute. So we encourage EPI countries to really listen and create key messages that are context specific. So in some countries, we've seen that it's better to approach HPV vaccination from the angle of cervical cancer prevention, because we've seen that disconnect where countries are vaccinating, but like you said, kind of like threatening messages to say, oh, you need to get your girls to be vaccinated, and curating the messages like it's a girl vaccination. Why currently Gavi is supporting just girl cohorts to be vaccinated. We understand that we should bring key messages from the angle of cervical cancer prevention to say this is a vaccine to prevent cervical cancer in the future. So we've seen that work in some communities, and in our communication strategies, we also tend to be more reactive than proactive. So we also encourage countries to have a crisis communication plan. So it's not when you start seeing anti-vax messages, anti-HPV messages in the media that you start reacting. Before a country introduces, before you do a catch-up, or just generally in your routine program, ensure that there's a crisis communication plan tailored specifically for HPV from the angle of life course immunization. So the girl is now 9. It is expected that when a girl is 9 or 10, she should get her HPV vaccine so as to prevent cervical cancer in the future, just as you would also preach the gospel of PCV. So we shouldn't really treat HPV too differently, although there are other angles to HPV vaccination, but we should just try to platform HPV as through the life course immunization gospel to say, yeah, it's now time for you to get your HPV vaccination to prevent cervical cancer. So all I'm saying is we are encouraging countries and EPIs to really key into community listening, social listening. What does the community want? We've seen that in some communities, they don't talk about cervical cancer because they don't understand. Like when I went to Liberia just recently, they kind of preach it with like end of the womb cancer kind of thing. So what does the community want? What does the community understand? We should ensure to build trust and tailor key messages that are context specific. Thank you.
Thank you very much, Mary.
Thank you very much, Fumani, for that good presentation. And thanks very much for the comments. I'll try to react to what my brother was saying that side. Many times we've realized that at times we forget the key people in our teams. The key people I'm talking about here are health promotion officers. So as long as in a program you don't have a health promotion officer, you tend to run the risk of developing those threatening messages, because health promotion officers are skilled to develop messages that are cultural sensitive, messages that can trigger behavior change. So I'll really urge us to work closely with health promotion officers in our EPA programs to avoid having such setbacks. I am saying this because before I joined the EPA program in 2014, there were those issues. I had to align it to help them understand and know the importance of developing a communication strategy. The way she was saying it, it is very important. There's no way a program can run without a communication strategy. And that communication strategy, the expert behind it is the health promotion officer. Thank you very much.
Thank you very much, Rose.
So we also have a comment online, and it adds on to what Joyce just said. So the comment is from Cornelius. He's just saying that the HPV message has been progressively accepted in his country. I just forgot to ask Cornelius, which country is this? And he's saying because of good advocacy, and he also just mentions that they saw an increase in uptake when the boy child was added to the program. So he says from Cameroon. Yeah.
Okay, I think that I wanted to share the experience of Cameroon that she's talking about. We introduced the vaccine in 2020, and we had some issues because of this religious issue. The Catholic in Cameroon, more than 80% were Catholic, so we had a problem with the Catholic institution. We were not d'accord so that the vaccine should be introduced in the country, all that stuff, and it was we had a great problem. So the coverage were very low and all that stuff. So with what we had, like we continued, and then we realized that we tried to develop some other strategy. Like at the beginning, they were saying that it was it would lead to the sterilization of girls. So we did the gender inclusion, but even with the gender inclusion, it still continues. So at the beginning, we were talking about prevention of cervical cancer, but we realized that the population, the cervical cancer, you cannot see the cervical cancer, but what they are seeing is condyloma. So we changed our communication tools. We use the image of condyloma acuminata by showing on the differences and all that stuff, and we try to do it with the community. We did not do a community engagement. We did community dialogues in some communities that we came. You group the community, you discuss with them, you show them the images, and we realized that it was a great success with this community dialogue. So when we talk about condyloma acuminata, we realize that we will not just focus our message on the prevention of cervical cancer. We focus our message on the prevention of all the others infection or diseases that HPV can, and that help us to, as Cornelius was saying, the vaccination coverage with HPV is really going up. So we try to change, not only talking about cervical cancer, but all the other pathologies that are around are also the gender, we are gender sensitive. So boys and girls. It's true that Gavi does not support the boys, so the country has to chip in something to buy the vaccine for the boys. This is what we are having like as a challenge as a low income country. So we are trying to mobilize for and maintain boys and girls vaccination is making really EPI or HPV optic to climb up a bit. Thank you.
Thank you so much. Just a follow-up comment on his. I think also it depends on the community. So I do qualitative research as part of my PhD. So it's on maternal vaccination and childhood, but the HPV thing, it came up during the qualitative interviews with mothers, and they were saying they were hesitant towards routine childhood vaccines because like for many reasons that maybe Hanali and we'll talk about it, the disease may disappear. But they told me some of them, I may consider the cancer vaccine. So I was like, why? Because it's cancer, it prevents cancer. So I think it depends on the community. In some communities, the word cancer will be like very like shocking. And if they know it prevents, I think it's also like the communication, as Adele said, because when you say HPV vaccine, it's the problem. So I think you need to say maybe cancer vaccine. It came up as a code in my research, and I think it depends on the community. For some communities, cancer will actually work very well. So I will take the last comment or question, or the last two. Okay.
Yes, my intervention is on the decrease of the uptake of the vaccine. And when we are, if I look at all the intervention, it's about the communication. But I think our communication still be one-way communication. We are bringing information. We are bringing our service. We are bringing the best things that think it's good. It will be good for the people. But we don't listen to the people. And I think this is the new thing that we have to put in our work. For me, it's a new paradigm that when we are talking about the feedback mechanism.
Yeah.
Because the feedback mechanism is the two-way. We have to listen to the people. We have to collect all the information that we get in the community, and then to analyze, to understand, to better understand, and then to provide the good information, but not the good information in the way that we are trying to push, but in the way to resolve the request of the population, of the community. I think this is the one thing that I could share with my colleague to say, we have to build the feedback mechanism, part of our communication practices. Thank you.
Okay, maybe just to also add to the communication, I think the other one is also how we are delivering the services. Because I feel at times we're seeing situation when we've combined the HPV vaccination together with any other routine immunization. We know our healthcare workers are used to the routine immunization where our target age is actually the children that are below the 5 years. Then we have HPV that needs to be dedicated into the schools as we offer this vaccination. You will find that the vaccination team will carry the HPV and all that, but we have that point that we call the outreach activity, outreach point, where we expect to find maybe the out-of-school girls, but we notice that a majority of the schools that we're targeting when it comes to HPV, we can only find them in the schools. Thought I just add that to the communication.
So Fumani, we're ending. Do you have a final thought or something to say?
I think just to say that my takeaway from this discussion is that HPV communication and demand creation might come up as one of the LSR topics that we tackle. Looking forward to have you expand on this discussion in our next steering group. Thank you.
Yeah. The good news is Fumani is also a delegate, so you can engage with her. Yeah, at any time before the course ends. Big applause. So I just forgot that I didn't introduce myself. So my name is Iman, and I'm originally from Tunisia, recently became South African. So my next speaker, and this is really my favorite part of the session, is Claire Cutland. So Claire, it will take me an hour to introduce you, what you're doing. Is just like I will say what is relevant to our session. So Claire, she's the scientific coordinator of the African leadership in Vaccinology Expertise Alive Consortium. Claire was a project lead, principal investigator on numerous phase 1, 2, and 3 pediatric and maternal vaccine trials. One of them is the phase 3 maternal influenza immunization trial in HPV positive women. And she will talk about strengthening maternal immunization in Africa, a critical link in life course vaccination. Thank you.
Thanks, Simran. And thank you to the course coordinators for inviting me to present. So I'm going to try and keep to time. Just shout when I have to stop. Okay, so today I'm going to give you a very brief overview of a topic that's very close to my heart, and that is vaccinating pregnant moms. A lot of the work that I've done and being in vaccine research for many years, many of the vaccines were given to children. And many of us come from a medical or pediatric background, and which children can we not protect? Often it's the littlest of the little. Sorry, I need my glasses to see this. Okay, so just as an overview, why do we immunize pregnant women? I'm going to go through briefly the recommended vaccines that are available, touch briefly on vaccines that are in development, and then also look at what recommendations are available. And I'm going to touch very briefly on the Myrna project. So we've heard a talk earlier by Prof. Dlamini on life course vaccinations. Pregnancy is a fantastic part of life course vaccinations. It is a time where there are lots of healthcare worker visits. So it's a wonderful time to get hold of those moms and to vaccinate them. But we're not just protecting the mom and the fetus. We're protecting the newborn, and we're protecting slightly older children, and we're protecting basically other people throughout the entire life course. Okay, so why do we vaccinate pregnant women? Well, we know about the Millennium Development Goals, yes, which have finished and they've now been replaced by the SDGs. But what happened during the MDGs? MDG 4 said that wanted to reduce the under 5 child mortality between 1990 and 2015. So were we successful globally? No. What happened in Africa? Definitely not. Was there a reduction in under 5 child mortality? As you can see on the far left, yes, there was a significant reduction, but it didn't get down to where the target was. So although there has been a reduction in under 5 child deaths from over 12.5 million children every day down to every year, down to 5.5 million children every year, there's still 5.5 million children who die, which means who flew here? I did. It means taking 50 of these planes every day full of preschoolers and flying them into the ground. Okay. So that's how many children die in the first 5 years every year. Where do the children die? From these World Mapper maps, this really shows that the majority of child deaths takes place in Africa and in Southeast Asia. When do children die? So if we look at the timing, this is a fairly old article, but it very clearly showed that if you look at the yellow on this slide, that's the neonatal period, neonatal deaths, children who are dying in the first 28 days of life. So we're looking at 42 to 45% of all children who die under 5 years of age. So in the first 60 months of life, they actually die in the first month of life. So unless we address this cause or this time of child mortality, we're not going to be able to adequately reduce the under 5 child mortality. So there's over 2.7 million under 5 child deaths that actually occur in the neonatal period, the first month of life. So if we look at when do we vaccinate, so we love vaccines. I've worked in vaccines for 25 years, but when do we vaccinate? From the EPI schedule, we know that there's a few vaccines that are given at birth, very few, BCG, hepatitis B, birth dose, OPV. Okay, when are the next vaccines given? 6 weeks, 8 weeks, second month of life. Okay. What happens between day 1 and day 42, 48, 50? Okay. There's this period of lack of early immunization, and it's a time at which those babies are at very high risk. It's also a time at which they are at high exposure. Who has not gone and kissed their sisters, brothers, grandchild's little newborn? Okay. They're exposed to the preschoolers, to the toddlers, to the siblings, etc. They're exposed to lots and lots of bugs. Okay, so what are maternal vaccines? So these are vaccines that are given during pregnancy. They help protect the mom, they protect the baby, they protect the fetus from serious infectious diseases. So what you're doing is you're actively immunizing the mom. You're giving the mom the vaccine. So that's an active immunization of the mom. You are passively immunizing the fetus and the baby because you're not physically sticking a needle into that fetus, but the mom is making antibodies, and those antibodies are crossing the placenta and they are protecting the fetus and subsequently into the breast milk and continue protecting the newborn baby. So why do we need vaccines? Many serious infections occur when babies are very young and their immune systems are too immature to mount their own responses. Also, if any of you have worked in pediatrics, you know that a newborn baby, a neonate, can go from well healthy eating to very ill and almost dying within a case of a few hours. We always had a thing in neonates where if the baby looks at you skew, you stick needles in them to try and find out why. Okay, and it happens very rapidly. So going on to what vaccines are recommended for pregnant women. So there are several vaccines that are available and recommended. So the first one is tetanus. So it's a part of my slide is not showing, and I'm not sure why. Okay, so tetanus is caused by Clostridium tetani. It is a bug that is ubiquitous in the environment, whether it's at rusty nail or whether it's at cow dung that's put on the umbilical cord post-delivery, there can and will be tetanus spores there. So if we vaccinate pregnant women against tetanus, we can reduce tetanus in both the mom and the newborn baby. Tetanus can present as in 4 different types. It can be the global tetanus, where you get that epistatonus, those severe muscle spasms. It can be facial tetanus, can just affect a part of the body. Neonatal tetanus is often that global body-wide tetanus cause. Okay. So how do we prevent neonatal tetanus? Back in 1980, the World Health Organization estimated that over 800,000 neonatal deaths were caused by tetanus, and that the maternal mortality was also high related to maternal tetanus, and many of those related to unclean birthing practices and management of the cord. So back in 1989, the World Health Assembly adopted the resolution to eliminate maternal and neonatal tetanus through maternal immunization, and to try and eliminate it initially by 95, didn't happen, 2000 didn't happen, but essentially tetanus toxoid vaccination, clean deliveries, and improved surveillance has definitely reduced the amount of tetanus cases globally. So these maps show when between I can't remember the dates, 1980 and 2020, which countries did have tetanus toxoid vaccination in their EPIs. What happened with tetanus toxoid? What we can see is that there was a significant decrease, 78% reduction in neonatal mortality related to tetanus from when the tetanus toxoid vaccinations were introduced. Does South Africa have tetanus toxoid vaccination available? Yes, we do. The World Health Organization recommends a 5-dose course through the period through adulthood, particularly in areas where there is inadequate tetanus toxoid coverage during childhood. The first tetanus toxoid vaccine is given at as early as possible in antenatal care, the first antenatal booking visit, another one a month later. And then 6 months later, it could be in the next pregnancy, and then in subsequent pregnancies as well. The next pathogen I'm going to focus on is pertussis or whooping cough. So bordetella pertussis is highly contagious. It's got a reproductive number of 5.5, and pertussis affects people of all ages, but it's of particular concern in young children. And in young infants under the age of 2 months, these are the children who are at highest risk of severe complications, including death, hospitalization, pneumonia, and so on. Pertussis vaccines are administered in the EPI, as we know, at 6, 10, and 14 weeks, or 2, 3, and 4 months, depending on where you are, with a booster at 18 months and a booster in childhood, in later childhood. In 2009, South Africa switched from a wholesale pertussis-containing vaccine to an acellular pertussis vaccine in our EPI. And what has happened because of that? So what's happened is the disease burden has shifted from young children into older children and adults. Over the past few years, we have seen an increase in the number of pertussis cases, and this is potentially related to that switch from wholesale to acellular pertussis vaccinations. We have seen, quite a few pertussis cases in South Africa and globally resurging. So back in 2011, there was ongoing surveillance in the UK for pertussis. And what you can see on this graph is the surveillance cases. There's always some pertussis around, with the blue line at the top being the infant under 3 months of age children. And back in 2010, suddenly there was a significant increase in the number of pertussis cases that were seen in the UK. Public Health England implemented very rapidly a maternal pertussis vaccination. And what this graph shows is the gestational age at which these women were in the different colors when they received their vaccines over the year. And so some of them, obviously, when they implemented the vaccination rollout, there were some moms who were about to deliver. So they only had received a vaccine like at term or just post-delivery. And as the time went on, many women were receiving it in their second trimester. What happened to the pertussis outbreak is you had a very, very rapid control and decrease in the pertussis cases, purely related to the rollout of maternal pertussis vaccination. So what's happened here? Pertussis vaccination has been recommended, so maternal pertussis vaccination has been recommended by the World Health Organization since 2015, by the CDC since 2012, by the South African Society of Obs and Gynae since 2020. As of December 2022, we had ongoing laboratory surveillance, but we didn't have a pertussis vaccine available in South Africa. In the public health sector, but this changed, and as of 2024, the tetanus toxoid that was administered to pregnant women was replaced by a Tdap, so pertussis-containing vaccine, which is given in the second trimester. Moving on to influenza, what this graph shows is a very clear indication of what happened in the 1918 influenza flu season, where you had influenza causes a significant increase in pregnancy loss, and then more pregnancies later. So, so this pregnancy loss is related to first trimester miscarriages in women who had influenza. There's ongoing hospital surveillance in South Africa and as in many other countries in the world. And some of these data from Cheryl Cohen show that the highest burden of disease and influenzas in children under the age of 1, with many of them in the first 6 months of life. There is an influenza vaccine available, but the recommendations is only to give it from 6 months of life, 6 months of age. Pregnant women are the adults that are at highest risk for severe influenza complications, and HIV-infected adults also have a 4 to 8 times higher risk of influenza hospitalization and greater incidence of influenza-related deaths. We've been involved in multiple trials, including a large trial in which we vaccinated pregnant women to assess their protection. And this was done with 2 other studies in Nepal and in Mali as well. And long story short, influenza vaccination administered in pregnancy is safe, and it reduces disease in the mom, and it protects the baby as well. So the World Health Organization recommends seasonal influenza for the highest priority being pregnant women, and then also for children who are 6 months to 5 years of age, the elderly, and other people, healthcare workers, and people with specific illnesses. COVID-19 vaccines, just got one slide in here. Pregnant, from what we know, pregnant and postpartum women and the infants are at very high risk of severe COVID-19 related outcomes. There's a wealth of evidence proving that COVID-19 vaccines are safe. They protect against adverse events in the pregnant women and in the infants. And there's multiple groups that recommend COVID-19 vaccination of pregnant women. As Sip was already mentioned this morning, and Albie, I think it was, we currently don't have COVID-19 vaccines available in South Africa. Many countries do. If you do, vaccinate pregnant women, please. Moving on to another pathogen, which is quite exciting, is respiratory syncytial vaccine. So over the past few years, I've moved these set of slides from vaccines in development to vaccines that are recommended. So if any of you have got children or have worked in pediatrics, you do know that RSV is a leading cause of severe lower respiratory tract disease in infants and in young children. It's the second leading cause of death in children under 1 year of age, and just about every single child in the first 2 years of life will have an RSV infection. So the early days of RSV vaccine development were very, very challenging. In the 1960s, there was a formalin inactivated RSV vaccine that went into clinical trials, but it caused enhanced respiratory disease subsequent to a natural RSV infection, with the death of some of the children who received the vaccine after a natural infection. These children experienced a severe immune response that caused major respiratory symptoms with a couple of deaths. As a result, RSV vaccine development really stalled for years. A lot has been learned. There's been many graves along the side of the RSV vaccine development pathway. One of them we were very, very involved in, and that is the Novavax vaccine. This was a vaccine, a nanoparticle vaccine that was developed by Novavax, and we were involved in the phase 3 clinical trial. Just to show you, these are the trials, the phase 1, phase 2, and phase 3 trials that were undertaken, obviously at large expense for this vaccine. So you can see it went through, it was safe, it was proved to be immunogenic. And when it got to the final phase 3 trial, it showed that it did not fulfill the primary protocol specified outcomes. So it was stopped and it never went to market. So this, as I say, was a nanoparticle vaccine, but there's been more scientific progress since then, and there's been a lot of focus on the RSV fusion or F protein. So the RSV fusion protein is a part of the virus that allows it to fuse to the cell. It enables the virus to invade the cells and cause infection. The RSV F protein, though, is very unstable, and it undergoes these dramatic structural changes between a pre-fusion and a post-fusion state. So the Novavax trial particularly focused on the post-fusion state. So through the key scientific breakthrough that has really helped the RSV vaccine pathway is the identification that this pre-fusion or pre-F state of the protein is really, really important. And vaccines that contain a stabilized pre-fusion protein induce induce robust responses and protect against diseases. So there's been these pre-fusion vaccine trials that have been done, or pre-F RSV vaccine trials. The large phase 3 trial that was conducted was called Matisse. It was conducted across 18 countries, including in South Africa. And this trial proved that the vaccine is safe and effective at reducing neonatal and infant RSV disease. The vaccine is now available and marketed under the trade name Abrysvo. It received approval in Europe in August 2023 and in the US also in August 2023. There's been a lot of discussion about when do we give this vaccine, at what gestational age. One of the things that was highlighted during the Matisse trial was that there was a preterm safety trigger that was identified in middle-income countries, particularly South Africa and Argentina during the trial, which showed that there was some of the vaccine recipients, more vaccine recipients had a preterm delivery than placebo recipients. So there's been a lot of discussion around when do we give this, at what gestational age. And as you can see from this slide, Europe recommends to administer the vaccine between 24 and 36 weeks of gestational age, where in the US it's recommended to be given between 32 and 36 weeks. When will this vaccine become available in low and middle income markets? Well, back in September last year, 2024, the World Health Organization Strategic Advisory Group of Experts on Immunization released a statement and a decision to say that given the global burden of RSV, SAGE recommends that all countries introduce passive immunization for the prevention of severe RS disease in young infants. This passive immunization includes maternal immunization with the vaccine, and it also could cover monoclonal antibodies, which I will mention briefly now. There is ongoing work now to develop an affordable multi-dose vial, which could be rolled out in low and middle income country settings. Just very briefly, what are monoclonal antibodies? So these are antibodies that are manufactured and given at birth or soon after birth, which can kill a virus or other pathogen. They protect immediately, and they don't require infants to produce their own antibodies. So this forms part of the passive immunization of young children against RSV. There are some, so there is a long-acting RSV monoclonal antibody called nirsevimab, and there's another one which is just come out of clinical trials with very promising results. And these are now available and marketed in several high-income countries, particularly across Europe and across the US. So the pathway for preventing RSV disease in infants has been long, but very happy to say that there is an RSV vaccine that is available. It is an RSV pre-fusion protein, and there are monoclonal antibodies that are also available. Okay, I have mentioned that the Matisse trial did show that there was this increase in preterms delivery, particularly in middle-income countries. So again, related to the World Health Organization, there's the SAGE announcement last year. SAGE recommended that it is of critical importance. Basically, okay, I can't read it all. SAGE recommends including a country in South Asia, but to do ongoing phase 3, phase 4 trials to assess if this safety trigger is a true safety trigger, and at what gestational age should we be giving this RSV vaccine. So very briefly, there is an RSV trial called the RSV Impact trial, which was initiated 6 weeks ago. This is being done across 4 African countries: South Africa, Kenya, Ghana, and the Gambia. And the co-primary objectives of this trial are to evaluate the efficacy of RSV-AB pre-F vaccine to reduce confirmed severe lower respiratory tract infection in children under the age of 6 months, and to evaluate its safety in relation to preterm births using the strict Gaia level of certainty 1 or 2B, 1 up to 2B. So this trial will enroll over 13,000 pregnant women across these 4 countries. The trial has been initiated already in South Africa, with the other 3 countries due to initiate enrollment soon. So watch this space. Okay, very briefly on vaccines in development. Group B streptococcus is a leading cause of meningitis and sepsis in newborn babies, and 25% of all pregnant women are colonized with Group B strep. It can be transferred to the fetus before birth or during the actual delivery. In many high-income countries, intrapartum antibiotic prophylaxis is given where if women are known to be colonized with Group B strep because they're tested, they're given intravenous antibiotics during labor and delivery, and that reduces early onset disease, which is disease with onset in the first week of life. It does nothing to reduce late onset disease. So these data are from the US and with some of our South African data superimposed on top of it. There have been several GBS vaccine candidates. The first trial was conducted by Professor Carol Baker, who's in that photo with me, and this was against a type 3 CPS protein back in 1978. There's been multiple other vaccine trials that have been undertaken. It has been a very challenging pathogen to try and prevent. At the moment, there's a polysaccharide conjugate hexavalent vaccine in clinical trials. There's a protein vaccine in clinical trials as well, late phase clinical trials. And there is in future there's a bifunctional PEG linker technology, which will be another vaccine candidate going into clinical trials soon, and multiple antigen presenting systems. There's trials on that as well. Conducting trials in Group B strep vaccines has been challenging. The incidence of disease is quite low, although the complications of the disease are significant. And there's been multiple strategies that have been considered. To do a phase 3 trial for a Group B strep vaccine would require between 40 and 60,000 pregnant women in an area where there's no or minimal intrapartum antibiotic prophylaxis. So that is a huge challenge by itself. There's a lot of work happening on colonization and on serocorrelative protection at the moment with the Gaston consortium. And definitely don't have time to get into all of the details. But if you want to hear more about Group B strep, please come and join us at the Group B strep conference, which is taking place in Kenya in February next year. And you'll be able to hear all about the updates on Group B strep vaccine development. Very briefly looking at vaccine equity, where are vaccines available? So if you don't know what this map is, it's the World Health Organization regions. And there are different regions. So one of the master students that I'm working with looked at the recommendations for maternal immunization globally and has put together almost like heat maps, in which she looked at what is the World Health Organization region, do pregnant women, are there recommendations for tetanus vaccine, pertussis, influenza, COVID-19 or RSV vaccines in pregnant women? With the different color coding, green meaning that the vaccine is recommended, yellow meaning that the country acknowledges that it's an important disease, but there's no specific country recommendation, and red that the vaccine's not recommended. So if we look at the regions, in the Americas, you can see the first green column is tetanus. So across the Americas, a lot of tetanus. The second from right is COVID. You can see quite a lot of pertussis and influenza and RSV vaccines that are recommended. Still a lot of white. If we look at the Eastern Mediterranean region, we can see tetanus, COVID a lot, a little bit of pertussis, flu, and RSV vaccines recommended in these different countries. When we look at Europe, this is where you want to have your babies, okay? Lots of countries recommend pertussis, recommend flu, recommend RSV. So this is the kind of heat map that should be changing over time, because as RSV vaccine and so on is changing, we should get more and more green in this map. When we look at Southeast Asia and the Western Pacific, again, tetanus is great. Tetanus is there. Okay, quite a lot of COVID, quite a lot of pertussis, flu, and some RSV coming up as well. What happens with Africa? Thoughts? Tetanus, yes. COVID, yes. Pertussis, 1. South Africa. Flu, 1. Okay, we need to change this map. Okay. How are we going to change this map? Multiple strategies, knowledge, acceptance, what is happening, are these vaccines safe, getting out to the community, what do we need to change? One of the strategies that is being used and one of the groups is MIRNA, Maternal Immunization Readiness Network in Africa and Asia. This is a consortium supported by the Gates Foundation. The aim of the MIRNA network is to identify, characterize, and support the platform, policy, and preparedness requirements for introduction of potential new maternal vaccines to prevent infectious diseases in selected countries in sub-Saharan Africa and South Asia. So very briefly, there are 9 countries that are involved in the MIRNA network and doing a lot of work around different aspects, particularly cross-institutional country it's led by the Global South. There's a lot of cross-institutional and regional collaboration, a lot of leadership from within Africa. There's a unified approach, building on and expanding existing maternal platforms and advancing this body of evidence that's needed. With the key focus areas looking at vaccine investment, health systems readiness, and vaccine demand. It's pointless having a vaccine available and rolled out if nobody's going to come and get it. So all of these strategies are required. So in conclusion, vaccine preventable diseases cause significant burden of disease, death, morbidity, mortality in infants, young children, and in pregnant moms. And maternal immunization can protect the mom, the fetus, and the baby. There's a lot of safety and efficacy data available. There are some really great vaccines that are available, can and should be rolled out, with others, very exciting advances like Group B strep and MIRNA on happening. Thank you so much.
Thank you so much, Claire. The good news is there is no only these vaccines that are recommended for women, and because you are in Africa and we are the continent where most of outbreaks happen, so I'm gonna ask you a quick question. If you can touch on the recommended vaccine for pregnant women for disease prevention in specific situations. If you can just touch on those vaccines. There are other vaccines that can be used and they are safe among pregnant women.
So in specific situations, like, I mean, for example, in an outbreak situation.
Yeah.
So absolutely. I mean, I know Albie presented earlier on yellow fever. Is yellow fever a live vaccine? Should it be given to pregnant women? Not really. Has it? Yes, it has. Has it caused major issues? No. So in an outbreak situation, can you give them? You can ideally give it before pregnancy. Okay, so, but there's certain things. COVID was a perfect example. There was a delay in rolling out vaccines to pregnant women because of safety concerns, etc. And but when they were rolled out, who should they be given to? Who are the highest risk? It's the moms, it's the babies. So there's other situations. There's obviously other vaccines that I haven't touched on at all. Ebola vaccines. Are you going to vaccinate a pregnant woman with an Ebola vaccine? In an outbreak situation, absolutely. So it has to be very country specific. But one of the key things is saying that pregnant women deserve to receive the best medical care available. They should not be sidelined until all the data are available before they're even considered for vaccination. They have to be included in clinical trials, in rollouts, in implementation plans from early. And there has been great political, regulatory, etc., change over the past 10, 15 years to go from a point where it was don't touch pregnant women, they, you aren't allowed to do anything on them, to like, you need to now, you need to motivate why you are not including pregnant women, which is great.
Thank you.
So did that answer your question?
No, yeah, thank you so much. But there is like mpox, polio, all of these vaccines we can in pandemics, like in an outbreak situation, give it to pregnant women.
But it comes back to the whole life course vaccination. Ideally vaccinate before pregnancy for things like live vaccines, etc. But yes, in pregnancy is a great time where you can
And
see
also
them.
for the one that are not that are not recommended, they are just theoretical contradictions. Like we don't have a proof that, for example, MMR cause issue in pregnant women. It's just like a theoretical contradiction as well.
Yeah.
Thank you.
Thank you very much for that nice presentation. I just have a quick question. You presented some data on the resurgence of pertussis when they shift from the whole cell to the acellular vaccine. I just wanted to understand, do we know some of the factors associated with that resurgence? Was the other vaccine like inferior, like the acellular part or type of vaccine, was it inferior to the whole cell? And currently, which of the two is being used in the vaccination program?
How long do I have? Okay, so this is a whole other day-long discussion. Very briefly, the whole cell, the body mounts a fantastic immune response to the whole cell vaccine, but there are quite severe adverse events, okay? And the parents don't like those adverse events, okay? So there are far fewer adverse events to the acellular pertussis, but the immune response initially is good, but it wanes quicker. So there's a combination of things that happens as well as vaccination programs have been successful. So your disease circulating has decreased. So people are not exposed to the disease, which would naturally boost their immunity as well. But we're getting to a situation now where we've got 2009 was when we switched to acellular. Now those kids, 2009, 2019, they like your mid-high schools now. Have they had their 6-year, their 12-year boosters? If they haven't, what's happened to their antibodies against pertussis? Has there been disease circulating? Not much until a couple of years ago, so they hadn't been boosted. And now their antibodies have dropped. Okay. So it sort of highlights this whole thing about life course vaccination, boosting them. Now we've got some of these kids are now already falling pregnant at 15, 16. We need to vaccinate them.
We have a question online from Abdul. He says he knows Prof. Shabir's trial will answer this for us in the long run, but he says what factors could explain the observed differences in efficacy of RSV vaccines when comparing outcome in developed countries versus developing countries?
Again, how long do we have? From a biological perspective, not sure what the biological reason is for seeing that that increase in preterm in your middle income countries compared to high income countries. It's very difficult to explain from a biological point of view. The trial is going to answer that. Why we see it in multiple different vaccines that you do get differences between the responses to vaccines between children in low-income country settings, middle and high-income country settings. And it's multifactorial. So multiple things that impact that. So previous exposures to different diseases, previous exposures to the disease, to elements, to a whole lot, multifactorial.
Hi, so I was part of the group that is doing the RSV study here in South Africa for pregnant mothers. And from my experience, I don't know, maybe because it's a clinical trial, they're very strict in picking which moms get the injection. I'm just asking, like, when does it move from like, because they don't want any pre-existing anything, like, even if like they had a miscarriage or anything like that, they get excluded from testing the RSV shots. So, like, when do we make that jump to say, okay, the injection is safe, even, like when it's widely spread, because you can't be that strict in
Yeah.
real life. So
Sure.
how does that work?
Yeah, so in all clinical trials, you have to be very strict and define your population. You want to exclude your women who've had bad obstetric histories, multiple neonatal deaths, multiple miscarriages, and so on. That is standard in clinical trials. But obviously having real world evidence and being able to look at what happens in the real population, HIV positive moms, women who are obese, women, other pre-existing conditions, what happens? So the RSV impact trial is trying to be as real world as possible. So there are very few exclusion criteria for it. There are some things that are required, and this is because of the very specific requirement to assess the gestational age. We need to be very clear about how the gestational age is being assessed. So the trial is requiring an ultrasound, at least in the second trimester. An ultrasound in the third trimester is too incorrect. It's just too broad to be able to clearly assess gestational age. But the impact trial, which is ideally it should have been a phase 4 trial. I won't get into the details. It's called a phase 3 at the moment, but that is including women who are carrying twins, HIV positive, women who are obese. So yeah, but then if it wasn't for the impact trial, what are we looking at? Into phase 4, post-marketing, which is one of the reasons why when a vaccine is implemented into the population, there needs to be very close post-marketing monitoring happening. And data collection, because that is when you're rolling it out into the real world.
We have another comment and question from Abdul online. He's saying some researchers are of the opinion that changing from whole cell pertussis to acellular pertussis is a big mistake. And he says due to the waning of immunity over time, as you mentioned, and that whole cell pertussis should be sustained despite the adverse side effects. So he wants to know what your opinion is on this debate.
There's a lot of questions. It depends. Okay, so yes, the whole cell from an immunological perspective, the whole cell pertussis does continue and maintain your immunological, your coverage, your protection for longer. And should we convert back to a whole cell? There's a lot of discussion about that up to SAGE level. Some countries may convert back to a whole cell. Well, what is it going to do to the vaccine uptake? What is it going to do to people who, parents who will take their children for vaccination now because they don't have significant side effects, and then you're only going to give them a whole cell and they have side effects. Is it going to decrease your vaccine coverage? So it's a big balance. We want to make sure that there's adequate vaccine coverage and faith, belief in vaccines to make sure that there's high coverage, making sure that it's a good vaccine. Yeah, it's a huge debate. And it's one of these things that NITAGs should be discussing. So as a country level, so I'll hand that back to everybody else.
I just had a comment with regards to the strict exclusion criteria, but there was a vaccine effectiveness trial that was done post the Matisse phase 3 clinical trial in Argentina that showed in their setting it was just as effective in a real life scenario. I think the only caveat to that was that what makes them different from us is that they had a pre-existing immunization program, maternal immunization program. So they used all of those resources and existing program to introduce the RSV vaccine, which most of our countries don't have per se, which could affect the effectiveness. But I mean, there is data to show that it is effective in a real world scenario.
Yeah. So, and it's been seen across Europe, the data that are coming out of Europe and the US on the reduction in RSV over the past year or so since RSV has been rolled out, the RSV vaccine's been rolled out, are astounding. It's fantastic, fantastic results. Yeah.
Thank you so much, Claire. A big applause to Claire. So now I'm gonna introduce my last speaker for this session. Also, it would take me an hour to introduce her, but so we'll be having Dr. Beverly Cooper, and she has over 30 years of experience in medicine, mostly in infectious disease. And I'm just gonna say some like highlights from what she's been doing. Like for the last 10 years, she was at Sanofi Pasteur. She had several roles, but ending with a global role as global medical vaccine expert. She also worked in the interim board of director as the executive officer to establish marketing code authority for health products industry in South Africa. She also had the position of brand public affairs and policy manager at Pfizer. And also a medical director responsible for clinical trials, regulatory affairs, for pharmacovigilance, medical affairs in South Africa, as well overseeing similar duties for sub-Saharan Africa. We're so happy to have you, Dr. Beverly, and yeah, she would take us through a talk on cholera outbreaks. Thank you so much.
Okay. All right, so I just want to thank the organizers for inviting me again to give this talk. It's a new talk this time. This is all on cholera outbreaks in Africa, focusing on Africa, but I'll start more broadly in the beginning, and protecting underserved populations through vaccination and public health action. All right, so it's always interesting to go back to history. And I hope I've got lots of historical events for people in the room as well. But the thing that'll strike you immediately about the talk that I'm going to give is that this is a disease of antiquity. So, you know, how is it that we still have cholera in 2025 when we had it at 500 to 400 BC? So that is one of the very interesting questions. And then for the epidemiologists in the room, are there any epidemiologists? Well, for the epidemiologists, there is in 1854, John Snow, and that was theoretically the first epidemiological experiment because he was the first one who worked out that if you drank water from this particular water tank, you got cholera. And then the person below him is the person who actually identified cholera as the pathogen. And then a little bit later, Robert Koch confirms this entire theory. And then the other notable one is only in 1959, which is, you know, between 1956 and 1959, working out that you actually needed a very specific kind of oral rehydration to deal with cholera. All right, so just talking about the pathogen, for those that are not familiar with the field, but there might be a lot of people in the room that are dealing with cholera right now, but just as a reminder,
It's Vibrio, it's a facultative anaerobe, and it's from contaminated food and water. But the most important thing is it remains a global public health threat. The serogroups are important. They're 2, 01 and 0139, and this has important implications for outbreaks as well as vaccine production as well. There's no difference between the type of disease that is caused by either one. And 01 has been responsible for all of the recent outbreaks. 039 is contained more in Bangladesh and doesn't really move out of Asia. And this is also important from a vaccine development point of view. There are 3 different serotypes. There's Anaba and Ogawa. Those are the 2 most important ones. And Hikajima is quite rare. The virulence relates to the cholera toxin, and one of the components of the toxin causes attachment onto the intestinal epithelium, and the other one is responsible for the actual toxic impact. So we are now in a situation where cholera has spread almost over all of the, during the 6 pandemics, over all of the continents. And we are currently in the 7th pandemic, which started in South Asia in 1961. So there seem to be all the 1 years. Africa in 1971, the Americas in 91, and cholera is now endemic in many countries. The key thing about cholera is it is known to be a disease of poverty, affecting millions of people living in areas with very difficult access to clean drinking water and inadequate sanitation and hygiene. So you can look at a lot of different metrics. This is one from WHO where the estimates are anywhere between 1.3 and 4 million cases of cholera and 21,000 to 143,000 deaths on an annual basis. So I thought, let's look at 225 and how we're going to almost end the year. So we have already had over 500,000 cases and over 6,000 deaths. Now, this is absolutely alarming. And when we have a look at either the airplanes that crash or the rugby stadiums that are filled, you can get an idea of exactly how many patients are involved in the cholera situation. And the 5 key WHO regions, these are the metrics that have been collected up to the end of October. So we've still got 2 months of the year left, and anything can really happen, especially after the recent activities that we saw in Haiti and other regions. So it's an endemic disease and an outbreak disease. And this is also an important component when we start talking about vaccines as well. But the most important thing about cholera is also the fact that it is often underreported. So if you look at a lot of situations, these metrics are probably completely an underestimate because people don't want to report cholera. And I'm very well aware of some situations in countries where cholera has been declared, but you're not getting any more information out of the country after that, and you don't hear about it, and that's related to 2 things: economy and tourism. This is the disease mechanism, and I won't go through the detail of it, but the whole difference, this isn't your average gastro condition. The whole situation is related to the enterotoxin once the pathogen is attached onto the intestinal epithelium. And a very healthy 70-kilogram man can pass away over 24 hours due to the shifts in electrolytes and fluids. And that's the issue with cholera, is the suddenness and the huge shifts in electrolytes and fluid within the body that results in extreme rehydration that is very, very difficult to reverse once it happens. So there's a little leaflet all about the issues with cholera and the symptoms and how to treat it. But as long as we have the next 2 components, we will always have cholera. And they are these. Over 2 billion people every day drink water from fecally contaminated water sources. And over 2.4 billion people every day are without proper water, sanitation, and hygiene facilities. And this is why over all these, this disease of antiquity, we're now sitting with cholera still in the situation today. You can identify this pathogen, you can grow it in the lab, you can culture it, you can do a PCR. There are even rapid diagnostic kits, but the key diagnosis is clinical. So if it's acute watery diarrhea or if it's cholera of varying degrees of severity, it's mostly a clinical diagnosis, and we're not going to get to the point where we're actually going to make an official diagnosis, which is also one of the reasons why we have an underrepresentation probably in the numbers. And the treatment is rehydration in a very specific fashion and may require liters and liters of rehydration of patients. Antibiotics can be used. There are two different options, mostly used in extremely ill patients, pregnancy, and sometimes in children. So I touched on the outbreak dynamics, and this is really important because the outbreak dynamics will determine what happens in a country from a cholera point of view and also from a vaccine point of view. In endemic areas, there's evidence in the last 3 to 5 years, there'll be evidence of local transmission. In other words, the new cases that are happening in those areas are coming from within those areas, and they are not crossing borders and coming from other parts and other countries. The other opposite to that is the epidemic component, where an area or a country has had no cholera and all of a sudden found themselves with an explosive or confirmed case of cholera. And those are outbreak or epidemic areas. And as I said, the cholera transmission is related to all of these conditions: the high density living refugees, displaced persons, lack of clean water and sanitation, which is required for preventing patients from getting cholera. So this is a graphic that gives you all of the indications of how it is transmitted and whether it's cooked food or raw food, detected in wastewater or in water ecosystems or in sampling. There are a whole variety of different transmission routes for cholera. So in order to give you an idea of just what we're facing, I decided to look at the metrics at the end of 2024 and look where we are at the moment. And I'm focusing on global statistics right now, just to give you an idea of what the size of the problem is. So the important thing is that the number of cases is less. It's 500 over 500,000, but the number of deaths has increased, and we still have 2 months of this year to really go. And the number of countries that are impacted are roughly about the same, 32, 33. But the important aspect is that as long as you have cholera, it puts about 1 billion of the population in the world at risk for contracting this disease. When we look at also a dashboard, also from WHO, and this is at the end of August, we see the 3 biggest areas. So now I'm only focusing on Africa after I've done the global picture. And you can see that actually Eastern Mediterranean is even bigger. And Southeast Asia, so you always think of Africa and Southeast Asia as being the major territories, but actually Eastern Mediterranean is one of the biggest at the moment. And then a very few cases at the bottom in the green for Southeast Asia, and Africa is about nearly 200,000 cases in about 21 countries. So there's some areas that I'm not going to touch on in this talk. So when I focus just on Africa and look at the statistics there, over 250,000 cases, and you can divide them up depending on whether you want to say some are confirmed and some are probable or whatever, but the fact is it's still cases. And the number of deaths approaching 6,000, and this is up to September of 2025. The key major countries that are experiencing cholera at the moment are South Sudan, DRC, Angola, Ethiopia, and Mozambique. And this is an important point from a case fatality point of view. If there is ever a rationale for having a case fatality rate, and saying that it should be less than 1. It obviously should be 0 in the case of cholera. But at the moment, we're looking at a case fatality rate of 2.25%, slightly higher than last year, but it should be nowhere near this level. It's probably about double what it actually should be. And the trends are related to the kinds of climatic conditions, not only the living conditions, but the climatic changes that have occurred, especially at the beginning of the year with the cyclones on the coastal region of Mozambique, which also spilled into surrounding countries and affected, caused a great deal amount of flooding and affected the populations in those areas as well. So they all act as transmission hotspots. So if you ever want to get an idea of what the metrics really look like, there are incredible dashboards. This is one from WHO, but there are others. And on the left-hand side over here, it gives you all the countries, so you can actually go and look for your own country and break it down in alphabetical order. And then over here, it will give you the number of cases as well as the number of deaths. And then from the color coding, and I'm just going to focus on Africa, and you can see what the color coding looks like. It'll give you the number of cases. So from the dashboards, you can actually get a huge amount of information about cholera in your own country. We must not think that because South Africa was not color-coded in that last one, that we don't have cholera. We absolutely do have cholera. And we had an acute outbreak in 2023. And you can see that it was from coming from bordering countries. And in no time at all, we had 199 cases and 47 deaths. And it affected quite a number of the provinces before it came under control. So when we look at the risk factors and the challenges faced by vulnerable and underserved populations, as I've said, and we've mentioned throughout what the vulnerable populations are, children under 5 are definitely a big contributor towards the mortality rate, displaced communities, urban slum dwellers, and then once again, we start looking to barriers for prevention and care, which is related to limited access of services and poor sanitation and water. And then, of course, if we look in the African continent, we've had a lot of insecurity, a lot of instability, and that certainly contributes to what's happening on the cholera front. So this is a very busy slide, and I don't want anybody to think they need to read this at all. If you want to go back and look at the slides, you are very welcome. But this is a very interesting article. So what it does is it tells you about the challenges of cholera in Africa, and it gives you all the categories that are responsible down this column. Then it tells you about the key causes and patterns, and then it tells you what's happening in sub-Saharan Africa from a context point of view. So it really provides a lot of information on the causes of cholera in our continent. I want to give you some case studies and some trends, and I'm just going to give you a couple of graphics. And of course, what's happened is that we had El Nino last year, which had two things that happened. One, an incredible amount of drought, followed by additional cyclones and destructive rainfall, which occurred and affected a number of different countries at the beginning of the year. Then we have the conflict and displacement and the disease outbreaks. And then the continent itself, which we've had all through the week, is grappling with other major diseases. And we think of all of the diseases that we've spoken about this week, which are malaria, mpox, measles, and other infectious conditions that are threatening millions of lives. And then, of course, all of these kinds of especially climatic conditions and insecurity and strife and displacement of people, that has a huge impact on food security. And when you have a situation like that, what happens is you end up pushing the under 5s into acute malnutrition, which makes them even more susceptible to cholera and other infectious diseases. The last one I've highlighted, I think I should have put it into red, because the biggest impact, well, not the biggest impact, but one of the major impacts that we've had is the reduction in funding that happened at the beginning of the year from US funders, which supported a number of programs within Africa that suddenly disappeared. So that has actually led to all sorts of other problems all of its own. So I want to show you these humanitarian snapshots. These are from OCHA, which is the UN Office for Humanitarian Activities. And if you have a look at these graphics, it comes with a lot of explanation and what have you, but it gives you an idea of what's happening from a humanitarian point of view. And this is up to August of 2025. So it describes the displacement of people. It describes cholera there, the little black icon, and it talks about the countries. And in the next one, this was the OCHA report that happened after the 3 cyclones that happened in Mozambique and the subsequent rain and spillover that happened into bordering countries as well. So the interesting thing is that tells you how many people are impacted, but it also gives you an idea of the kind of financial commitments that are required and the kind of financial commitments over here that really happened. And that's when you see problems. Like if you need 197 million US dollars and you only get 22 million, that is going to be a significant problem to be able to rebuild infrastructure in countries. Then I don't want anybody in the world to think that cholera doesn't belong in their country and they will never be impacted. So here are here is one particular case study which showed that cholera was imported into Europe from holy water taken from Ethiopia into Europe, which resulted in a little outbreak of cholera. So, you know, when anyone says, I'm sorry, cholera is not my problem, it actually is your problem. Okay. So, and then I also want to sort of reinforce the issue that Radzani said about equity. So if you're in a country like Somalia and you cannot afford the treatment which is required for cholera, this is a socioeconomic inequality issue as well. Cholera vaccination strategy is very interesting, and this is where we start talking about what's happening within the world right now. We all know, and this is anybody who's gone and read Plotkin's book, he'll tell you that vaccination is the most effective public health intervention, contributing significantly to the reduction of mortality and morbidity from infectious diseases in the 20th century. And I think all of us, we are here converted. We work in vaccination, we work in vaccines, and we've seen the impact of vaccination. But we've also seen in Tony's presentation this morning, the 0-dose children and the other children may not be 0-dose, but don't receive all of the vaccines. And this results in a significant amount of children dying under the age of 5 from infectious diseases, which really could have been prevented by vaccination. And then when we talk about vaccines themselves, are they available? Are they not available? Well, in low middle income countries, they can be affected by a lot of different factors. Things like the fact that their companies are not making them anymore because they're no longer profitable, or there can be uncertainty about the disease or lack of data, so they don't know how to forecast and they don't know how to predict how many doses they need, or vaccines are often not the focus of this huge portfolio of neglected diseases in low middle income countries. And then the other thing which was also touched on in this week, which was how do you fit a sudden vaccine into, which is not there all the time, how do you fit it into an EPI schedule that is designed for every child? Cholera has faced many of these challenges. So in other words, at some other point in time, there were a lot of manufacturers and now there aren't. So the first vaccine that was produced against cholera was a wholesale. It was also an injectable, and you can imagine that that is not very fit for purpose because it's hard to give in thousands and thousands of patients who are impacted by cholera. The next one that was produced and is still available, but now in the private sector, was a vaccine called Dukoral, but it's got 2 components, can only be given under certain types of schedules, and it varies depending on the ages. And so that one also wasn't fit for purpose. So manufacturing cholera vaccines is not an easy situation. But here's my first bit of a reference, which I'd really like everybody to have a look at if you have a chance, is to read up about this organization called IVI, the International Vaccine Institute, which is a philanthropic organization that deals with diseases that are, of humanitarian purposes. And they went into specifically designing and building capacity by working in a number of countries to develop cholera vaccines. So they made it their work and they made it their business. And because they know a cholera vaccine is a game changer, it will allow the patient to get the vaccine and to recover and allow the infrastructure to be redeveloped if that's at all possible, so the patient would not die. And that's why cholera vaccines are absolutely so important in an emergency response. Until everything else around, say, for example, if it's a flood or a typhoon, cyclone, or whatever, everything else can have an attempt at repair, but you're not losing 70-kilogram healthy men and also small children overnight from the ravages of cholera. So there is a position paper that tells you exactly how to use cholera vaccines. It was written in 2017, gives you all the data and tells you all about the vaccines, some of which are not available anymore now. But the problem is, in October 2022, there weren't enough cholera vaccines to go around. And that all that had to happen in that point was that from a 2-dose schedule, which should be given to everybody, vaccines became a single-dose schedule. Now, this was supposed to be a sort of intermediate temporary suspension and change in the schedule, but I can tell you we're in 225 right now, and that still exists. So we're still back down to the single-dose approach. And we need in the order of 2.5 million doses every month to be produced by cholera manufacturers. And at the moment, you'll see that there is only one. So these are the cholera vaccines. If you actually look them up on the FDA website, although from this morning, I don't know if the yellow book or the pink book or the FDA website exists anymore. But these are the vaccines that are available, but you'll see that some of them are only in the private sector and are not pre-qualified and are not available in every country. Dukoral is still there. If Albie was here, he'd tell you that that's mostly used in the private sector for travelers and people going to visit countries. Because they can actually take the different components and mix them up together, and they have got water to actually dilute the buffer. But right now we are sitting with, there used to be Shankol, Uvicol, and Uvicol Plus, which is exactly the same as Shankol. The one is in a glass vial, and Uvicol Plus is in a little tube, plastic blow-fill tube, but they are identical in terms of their components. And then what happened is that Shankol stopped being manufactured. And as a result, we only have Uvicol and Uvicol Plus, and they give good protection up to 3 years and can be even up to 5 years. And also they provide herd immunity for surrounding communities. So there's this mad dash to get new cholera vaccines. And Uvicol S was also one that was made by U Biologics, but it is a slightly simplified form of oral cholera vaccine. It was registered in 2023 and pre-qualified in 2024, and it is now part of the stockpile. So we have all the South Korean U Biologics vaccines that contribute, and they are the sole contributors towards the global stockpile. Hilcol is one that was produced and registered by Bharat, but it takes a long time, as Marina said yesterday, to get to the capacity where you can actually put out 200 million doses in a year. So that one is registered but not contributing to the stockpile. Then we have a new one, which is going to cater for the thermostability, and it's going to be a capsule. So that one is in development, and that is called Geocol and supported by Wellcome. The bottom line is that we are still sitting with 400 million doses as a deficit in cholera vaccines that are required every single year. So I'm building on something that Lawrence spoke about yesterday, and that is the stockpile situation. So I find stockpiles fascinating because it's absolutely the best way to get vaccines to populations in need in huge groups and acutely. So exactly the same as what Lawrence said. The first one that was developed was the meninge stockpile in order to be able to get masses of doses of meningococcal vaccine into the African meningitis belt where there was a huge outbreak. And in 2013, WHO established an OCV stockpile. So in the beginning, it was 2 million doses in 2013, 7 million it climbed to in 2016, but by 2022, it was 30 million. And that was at a time where we actually had enough contributors and manufacturers of cholera vaccines. But to date, so it just gives you an idea of how many doses you actually need. Over 300 million doses have been delivered in 31 countries through the stockpile mechanism. So there are lots of layers to the stockpile mechanism, but suffice to say it is under the Global Task Force for Cholera Control. There are lots of partner organizations that contribute towards the functioning of the stockpile, and they take all the requests that come from the countries, and then they ensure that they liaise with the manufacturers, they have the stockpiles of cholera vaccines, and then they get them out to areas where they are required in order to be able to control cholera. So this is the ideal situation where you've got a bunch of cholera vaccines that are used for emergency outbreak. So those are new countries that are experiencing cholera. And then you have the endemic cholera, and there's a group of vaccines over there. But this is not the case right now because we don't have enough vaccines to go around. They have very strict indicators of performance in order to be able to react to countries who are needing cholera vaccines from the stockpile as an urgent basis, and they should have started from the arrival of the request to the implementation of the program cannot take longer than 28 days. So it's a very efficient system. Now, here's another very nice dashboard that you can look at if you have got cholera or if you're interested in it. It's on the Global Task Force for Cholera Control, and it's a dashboard that tells you everything that's going on in cholera. So how many requests were there, how many doses went out, how many shipments were done. But I think if you look really closely, the requests, for example, over here were 276. But only 236 went out because of the number of doses. So there has to be prioritization. And then over here, the doses requested were 436 million, but only 298 million went out. So you can see that there is a problem. And when you look at another dashboard on the Global Task Force dashboard, you can see that the majority, this is now up to September 2025, the majority of the doses are going out for reactive campaigns and not for prevention. So we've had to change our whole philosophy about campaigns at the moment just because we don't have enough vaccines. We see the media responses. This is just within the last month or so, number of deaths. And, you know, it's hard to believe for me that there isn't a greater reaction from countries and governments in terms of how many cases there are. So I just want to show you what the case study was for the tech transfer to be introduced into BioVac. So this was in 2022. There was a prevention campaign in 4 countries that couldn't go ahead due to lack of stock. And this was the case study. I'm not unpacking it in any detail, but I'm showing you the press release that was announced. And that was between BioVac and IVI for a tech transfer between the two organizations in order to be able to develop cholera vaccines. And that's where we are today. So we've already been working on the new vaccine for 3 years. And as Marina said yesterday, it is in clinical trials. Here's another very good reference if anybody's interested in the mechanism behind finance. And it's the whole African finance manufacturing situation. So this is really important because, you know, we want to have 60% of our vaccines produced by 2040. And it may be a good idea if this is written as a commentary in the Lancet, so it may be a really good idea if you want to have a look and see how this mechanism is actually written up. So the big question is, Europe and North America don't have cholera anymore unless it's imported, so it's still their problem. And certainly Africa, Asia, and EMRO has cholera all the time and increasing. So why is this? So they had to go through all of that, the investment, the building of the infrastructure, the education, the advocacy, all of that, the surveillance, upping everything in order to be able to get rid of cholera. We need to do that in earnest in our different continents. Otherwise, we're always going to have cholera. So there is a public health response, and this is important because there was a global roadmap that was developed, and it outlined everything that has to be done to prevent cholera outbreaks and preventative campaigns, and to continue with that. So why is that so important? Well, the resolution promoting all of this was developed in 2018, so important, that's before COVID, at the World Health Assembly, and this is where the Global Roadmap 2030 was developed, and it said, right, we are going to set out a whole vision by the time we get to 2030, and we're all going there, right? We're all going to 2030, but I think we hope to be a little bit further ahead, and also we didn't plan on COVID to be in between. But what we have to have is 20 countries in Africa that are cholera-free, and we have to have a reduction by 90% of cholera deaths amongst everything else that's in the roadmap. And are we going to make it? So this is all that's involved: the leadership, the WASH, the building, the surveillance, the vaccines, etc. And then I think I found this, and I think it speaks to what's happened this whole week, that we better put the community in the center of everything before we start, and getting the community buy-in before we start rolling out all the other components. If we don't, we are not going to meet the Sustainable Development Goals at all. So the take-home messages are that we really need to understand that cholera is preventable, but it's still a significant disease, and it's still significantly distributed all over the world. There are high case numbers, there are high case fatality rates. There are countries that have cholera now that never had it before. We have a lot of conflict, mass displacement, disasters, and all sorts of things that are going on, which is making our ability to contain cholera even more difficult. The metrics are extremely high and getting higher every year. The Global Task Force for Cholera Control does not have enough supply of vaccines and capacity to respond, because what we'd usually do is we'd have outbreak campaigns and we'd have reactive campaigns, but we don't have enough vaccines. So we are looking for the AVMA situation to be able to develop cholera vaccines. So we need this policy. We need an integrated emergency response. Without that, we are not going to meet that strategic framework for 2030. And we might have to lean into AI, because here was a recent study, this is for Yemen, where they said, okay, if we collect all of the environmental information about the rainfall and the precipitation and everything, and we can predict whether this area will end up having cholera or not. So maybe this is something that we can also lean into over time. So cholera is preventable. We have the tools right now. We do need more vaccines, but we will have them. And we have the other tools today. We need political will And if we put all of the tools that we have and the countries all work together, we will have a way of dealing with cholera, and the end is in reach. Thank you.
Thank you so much. Perfect timing. And we have 10 minutes for questions.
Okay. How many people here are working in cholera programs? I'm amazed. Okay, I thought everyone would put up their hand. Oh, there's one. Ah, yes. Latif, yes, I know you are, definitely. Oh, there's one here. Sorry. Okay.
So I had a question and a comment.
Yes.
The question is around AMR. Obviously, we had the talk the other day, and I was wondering if you had any information around AMR with cholera, if that's a big problem or if that's something that isn't really an issue. And then the comment was also on the AI modeling, like you said. And I think the tricky thing is with that with these models, the data you get out is only as good as what you put in. So if you're having these underreporting, and I mean, even just your climate data, for example, all of these factor in. So it does become a bit difficult when you want to accurately predict. But I suppose longitudinally, the more data you have, the better. But yeah, just on the AMR.
All right, so let me start with the second one first. It's just something that caught my eye, because imagine if somehow we can predict and we can see what can be done. And I think everything's going to AI, so it may be something in the future that might be quite helpful. And then regarding resistance, I'm not aware of resistance to my knowledge. I don't know if Greg, Tony, or anybody wants to jump in, but I'm not aware of that being an issue. Thank goodness, because I'll tell you why. We probably don't treat it with antibiotics very often, because that's not the mainstay of the treatment, is rehydration. So, and the two antibiotics are still viable, as azithromycin and ampicillin, so they are still okay. So I think it's more the numbers.
Beverly,
yeah,
here.
Oh, sorry.
I think with prediction, just so I can follow-up comment on you, there is also statistical like prediction or predictive modeling. So, and it can be more accurate. So we use secondary or routine administration data and we do prediction, but it's not only AI, but also with like epidemiologists and biostatistician, we can do prediction, which can be more accurate.
I know, I'm going to be phoning you.
Okay, so we have another question.
Yes, that's Latif. Okay, finally, I got you, Latif, sorry.
It's not a question though,
Yeah.
but we were discussing here, the three of us, colleagues were asking if we really do need cholera vaccines, if we have intermittent outbreaks
Yes.
in the same country that do have cholera vaccines. So we're just discussing the need of combining with wash interventions, but wash interventions alone cannot prevent cholera because you need to reduce the number of susceptible population.
Exactly.
Susceptible people in the population who can actually get cholera.
Right.
I think then the question would be in a particular population, what is I mean, we know the duration of protection is 5 years, but we have seen communities like mine get cholera year in, year out after reactive campaigns. So maybe the strategy is not correct that we do reactive campaigns.
We're only doing reactive campaigns because we don't have enough vaccines. So that map that I showed you, which is all orange and little slices of blue every now and again, they're supposed to be more preventative. So in other words, in hotspots or PEMIs, you would be vaccinating those people because you know that is a hotspot. If you eliminate that, that is your one source that's gone. And then your reactive campaigns are the ones that pop up after floods, cyclones, etc. But at the moment, there's so many outbreaks that we've had to focus on reactive campaigns, and the preventative campaigns are not getting much of a look in at the moment. Okay. But you're absolutely right. It should be a balance, and that's why the Global Task Force should have vaccines in both of those arms, but there isn't enough to go around at the moment.
You mentioned floods there. with environmental surveillance, there's a myth that flooding causes more cholera. And she's saying yes, because that's what everyone believes. But actually, recent data has shown that you get reduced transmission with flooding. You get more cholera when you have stagnant water.
When you have stagnant water, yes.
But when you have flooding, the rain washes away the dirty water into the sewage system. Like,
yes, but then it pitches up at someone else's country.
Yeah.
You know, so that's exactly what the problem is. It doesn't go away, you know, it just doesn't go away.
Yeah, I mean, if you have good drainages, it's supposed to wash it into the rivers and reduce transmission, actually.
Well, I think there's two components which we actually saw also in South Africa, is that it's also about your water purification plants. Are they operating perfectly? And so the water should go into the water purification systems, and that should be purified, and water purification should result in water going out which has been treated. Now, what is happening in water purification systems in countries, especially where there's flooding and some of the infrastructure is disappearing? So I think there are a lot of elements that are coming into play here, but if I had a magic wand, I would have infrastructure put in place, I'd have proper purification systems, and I'd have vaccines. So I don't think we can get away from vaccines at this point in time, because that buys you time to put all the rest in place, and it stops people from dying because it kills people so acutely, and there's not much you can do about that. And also in communities where you can't reach people in time, it's better to vaccinate them so that you're buying time for them to be, you know, if they do get cholera, for them to survive. So it's a big job, but it's doable.
Okay, thank you, Bev, for the presentation. You mentioned how because of the high demand of the vaccines, we had to move from 2 doses to only 1 dose. And I had a question. I just wanted to ask if that did not affect how effective the vaccine was. Were we still able to elicit the sufficient immune response to sort of combat the disease? And if so, they did not affect how long we had immunity to that disease?
Absolutely. So in my one slide, I showed that if you had the 2 doses, it would give you up to 5 years of protection, and also herd immunity in the surrounding community. So that has been shown from an effectiveness point of view and from a community point of view. If you go down to 1 dose, we're looking at 1 year plus, then patients would need to be revaccinated, and we don't have the doses. So, you know, that was supposed to be a temporary measure of single doses in the strategy, but here we are in 2025 and we still only have a single dose. So I hope that won't, you know, when other manufacturers come on board, or U Biologics can increase their capacity and the other one can come on board, we can have enough doses to go back to the 2-dose strategy.
Hello, thank you so much. So I was playing around with the dashboard, looking at the data, and I saw that the case fatality rate was much higher in
Yes.
the African region than EMRA, where the case count is higher.
Yes.
So I was wondering why that is. Is that because of OCV being more available? Is it delays in ORS? Why do you think that's
I think
the
it
case?
relates to all of that. So the case fatality rate has gone up, and so that one dashboard where it's really the humanitarian dashboard, it also gives you an indication that patients are facing malnutrition. That increases susceptibility to a variety of different diseases. So I think the case fatality rate is going up for a whole host of reasons, not only because patients are getting cholera, but also maybe they're not getting treatment in time, they're not getting rehydrated in time, and also because children are being pushed into malnutrition in war type situations, and that makes them even more susceptible when they come into contact with cholera. So, You know, there are a lot of humanitarian issues that are going on in countries that are facing these levels of cholera.
Yes, mine is more of a comment to the question my colleague at the front asked about the single dose. So there's actually a study that was done, I think, in Congo, in 2 districts in Congo, published last year, where they looked at a single dose, and it actually provided about 50% efficacy for about 2 to 3 years, and then beyond that, efficacy dropped to about 30%.
Yeah, we
And
have the
it was
data on
even,
that.
yeah, so the efficacy was even less in children less
Yeah.
than 5 years of age.
Yeah.
So,
And that's exactly the case, but you can't say to yourself, we're going to give some countries 2 doses and some countries no doses. So that's the reason why this strategy was introduced, and it was thought to be a temporary strategy, but here we are in 225 from 222, and it's still in place. So we actually need cholera vaccines urgently. Okay, thank you very much, everyone. Okay,
Thank you. So we're not done. So we stay here, please. Before that, I want to ask the online participants to turn their camera on. So we'll take a group photo first of the online participant. So please, online participants, turn your camera on. So we will take a group photo of you first. Ah, not me, no, the other participant. Here we go. Hi, online. Cheese, cheese with.
Online guys, can you hear me? Okay, so on 3, we're gonna say AAVC. 1, 2, 3. Nice, thank you guys. Looking good.
So now it's us, and we're not going to lunch now. We're going to have a group photo. Unless you don't want to show up in the photo, you don't join. For now, we're going outside, and you will find the photographer who will direct us. So please, let's go outside, have the group photo, and then we can go and have lunch. Okay? Yeah. Thank you.